so on and so forth. And so I think we can see intramyocardial hemorrhage, we can see microvascular obstruction, and so we can get a lot of information on not just the acuity of an infarct, but also the prognostication for it as well. And so that's the nice thing about it, is we can characterize the myocardium very nicely.
You mentioned myocardial microcirculation. How do you detect microcirculation problem? Because that's something we can't detect on angiography, etc. So what are the things you look for in an MRI for microcircular dysfunction?
So when we do stress MRIs for patients who have potentially microvascular disease, the typical pattern that we see is subendocardial global ischemia during the stress imaging. But we can go one step further and actually calculate a myocardial perfusion reserve index, which is a surrogate for absolute blood flow. So it's been validated against PET imaging, where we can actually quantify blood flow, but through various techniques, we can actually quantify the perfusion of the myocardium at stress and at rest and calculate what we call a perfusion reserve index. And that number, generally is above 2 for normal patients, and anything less than 2 can either indicate epicardial coronary disease or microvascular disease. So a lot of these syndrome X patients with metabolic syndrome and diabetes and hypertension, who perhaps may have a clean coronary angiogram without many obstructive disease, but they have angina, we will try to quantify their myocardial perfusion reserve index. Now, with automated software and MRI, it's very easy to do. You effectively get your stress and rest sequences, and you put it into the software, and within just a few minutes, you can get these calculations done automatically.
Regarding this T1 and T2 relaxation times, do you need to have different standards for if you're doing it in different machines, or they uniform? So you do it in a Philips or a GE machine.
Yes,
there is a concern that you need to develop your own values.
Absolutely. That's 100% correct. So each scanner, not only the strength of the scanner, whether it's a 1.5 or 3T magnet, or if you do it on different scanners, even in the same institution with the same vendors, will have a different intrinsic normal myocardial time. We typically have a range for T1 times of, let's say, 950 to 1,000 milliseconds up to 1,100 milliseconds, typically is normal. Now, the way that we can standardize for this is by calculating an extracellular volume index, ECV. So this takes into account not only the native myocardial pre-T1 times before contrast, but also it takes into account the T1 times after the administration of contrast, and looks at the hematocrit of the patient. So this is basically a normalized ratio that more or less is independent of the scanner. So if we don't give contrast, each scanner will have a slight different variation in normal times, but if we do give contrast, then we can normalize it across scanners, across strengths of magnet with the ECV.
Okay. I mean, any suggestion about AICD implantation according to the percentage of LGE?
Yeah, that's a great question. In patients with hypertrophic cardiomyopathy, I think that's where we've made the most progress with this. If we say that the percent of late gadolinium enhancement is more than 15 or 20%, in those patients, we tend to think really strongly about putting an ICD in them. This, I think, will come in the guidelines soon. In patients who have, let's say, non-ischemic cardiomyopathies that can still have scar, or mixed cardiomyopathies that have scar and ischemic disease and non-ischemic disease, and have scar in the myocardium, I don't think we've gotten that sophisticated yet. We mostly rely on the ejection fraction. But I think that's an interesting area of research that's probably very hot right now, is trying to quantify that a little bit better. But I think that's a little bit further away. We're most developed in the hypertrophic world right now.
Dr. Jivar, how are we doing in terms of...
Shall I restart my unshare the screen? Is that the problem? I can unshare it and reshare it?
No, it's not at your end. Akhil, you're fine. I think the problem is we are able to see you well, but it's not getting relayed to the delegates.
I see. Okay.
You're fine. Dr. Jivar? Dr. Jivar?
The thing I am talking to Dr. Mohanan, he said that the problem is not yet to be solved. I think we will have to wait another 4 to 5 minutes. It is they are working on it. A team is working on it, and Mohanan is very concerned and worried. So I am reassuring him, and let us wait for 5 minutes more.
Sure.
Because important sessions are coming up, and I think it will be very unfortunate if we... But I think we can maybe temporarily close it, and then or I think we'll hold back.
We can have some question answers. We can take use of Akhil and ask some more questions. I would like to ask a
No,
question.
the problem is that these questions and discussions are very, very interesting. Unfortunately, only you are hearing it. That is the problem.
Okay.
Oh, I
That's
see.
unfortunate. Oh, that's unfortunate. Okay. We will hold then.
Right, one.
Akhil, a quick question. This is directly may not be related to this MRI talk, but we have quite a few interested youngsters come cardiology stream who want to get into cardiac imaging.
Yes.
How does that happen in the US? Meaning it's from the radiology stream or cardiology stream?
Yeah.
Because from your experience, I find you're quite comprehensively boarded in echo, CT, and so on and so forth. So how does this operate in the US?
You know, it's a big problem because some institutions are more radiology focused, especially with CT and MRI, and some are more cardiology focused. And so I think for youngsters who are interested in imaging, you know, I talk to many people every year about their career paths. And I think the most important thing is to find a program that allows them to do multimodality imaging. As a cardiologist, I think that's crucial if you're interested in imaging. And then I think it's, you know, it's probably the best format is what I had mentors in both radiology and cardiology who were able to teach me. But I think if you are interested in imaging, regardless of who the teaching might be coming from, I think it's important to get into one of the programs, and there's many programs around the country that you can focus on multiple imaging modalities.
Narasimhan sir, we can
Yes,
start
please.
the proceedings, sir.
Okay. Do we know from which slide Akhil has to start? Do you know where we lost him?
Video, probably.
I think around 1 minute before the end of that time. 1 minute.
Okay.
Okay.
Next.
So we can start from the approximately 1 minute before.
Yeah, this should be fine.
Okay. So I'll go ahead and start. So just to remind everyone, this was a patient that came in with a large mass attached to the pericardium, and we underwent an MRI to be able to understand what this is. You can see that in the cardiac MRI, the axial scout images, there's a large mass attached to the pericardium. 8 by 4 centimeters was recorded to be the size. And if you look at the 2, 3, 4 chamber SSP imaging, you can see that the LV function is normal. The mass is not necessarily being tethered and really looks like it's outside the heart within the pericardial sac. And then if I further characterize this with T1 weighted black blood imaging and fat saturation, the image does not saturate out, indicating that this is not fat-based. Now, what's very interesting, if I look at the STIR imaging, so STIR imaging allows me to look at edema. Now, this is hyper-enhancing. So this is a very edematous mass that's outside the heart. And if I look at first pass perfusion, which is injecting a few cc's of contrast, I can see if you look in this bottom portion of the screen that there is some uptake of contrast, which suggests there's vascularity to this as well. Now, when I move forward and I look at the late ganglion enhancement, I can see that there's this heterogeneous uptake within the mass of late ganglion. So there's some disruption of the architecture of this tissue causing some necrosis and then allowing the gadolinium to penetrate it. Now, putting all this together, I think there's a lot of differential diagnosis for intrapericardial masses. I won't spend too much time with that. But what is very interesting with MRI is that I can use these properties that I mentioned, T1, T2, late ganglion enhancement, perfusion, to be able to break it down as to what it might be. Now, if it's something like a lipoma or fibroma, this typically are benign, and I may not need to do anything. As you can see, this mass caused an effusion but didn't cause any other problems. Now, if I look at the cardiac masses in terms of tumors more clearly, what I see here is this patient ended up having isointense T1, hyperintense T2, and heterogeneous LGE, really making me suspicious for sarcoma. So what happened? We send this patient for surgical resection. This is the picture of the mass taken out. You can see it's massive, smooth. Generally, it was removed easily from the pericardium, and the pathology indeed was synovial sarcoma. So the patient eventually was discharged after 10 days, however, 1 month postoperatively developing some chest discomfort and worse with inspiration. Now I'll show you again. So we sent her for another MRI. The preoperative images, you see this large mass. Postoperatively, very beautiful images showing that the mass is mostly gone. But what's interesting postoperatively at 1 month is you can now see thickening of the pericardium. So the pericardium is now thickened and actually is enhancing with edema on T2 imaging as well. So it's a very bright sequence here. You can see really suspicious for a post-operative pericarditis. So this patient was treated with for a diagnosis with pericarditis, treated with colchicine and NSAIDs, eventually underwent chemotherapy for the sarcoma, and overall did very well. So in this particular case, CMR is invaluable for understanding what this tumor was and really even honing in on the pathology. Let me take you through two other cases very quickly. 60-year-old male with a history of coronary disease, with remote PCI more than 10 years back, well-controlled hypertension, comes in for a second opinion after being diagnosed with hypertrophic cardiomyopathy. You can see the EKG is very unremarkable here. Here's the echocardiogram, thickened septum, almost 1.7 centimeters of the mid-septum. And so this potentially could be hypertrophic cardiomyopathy. His ejection fraction is good, and his blood pressure is very well controlled. You can see actually here on the Doppler imaging that there's maybe a restrictive pattern of the filling. And then here's the strain sequences that show, the septal area of the strain is actually a little bit lower, and there perhaps is a little bit more what we think about apical sparing here. So we actually sent the patient for a cardiac MRI because I was not convinced this was hypertrophic cardiomyopathy. So we calculated the ECV, which came out to be very high, but most importantly, you can see this diffuse subendocardial delayed enhancement indicated by the arrows of the left ventricle, right ventricle, and even the atrium you can see here too. So this was highly suspicious for cardiac amyloid. I sent the patient for a PYP scan, and indeed was diagnosed with TTR amyloid. And since then, we started on a clinical trial with tafamidis, is doing well. So I talked a little bit about parametric imaging with T1, T2 times. It's very important because these types of measurements of T1 and ECV can really give us a clue as to what might be going on within the myocardium. So I can diagnose myocarditis, amyloid in this case, iron overload, Fabry-Anderson disease, or even just diffuse fibrosis. This is a nice graphic that shows us all the different areas of cardiac infiltrative disease and how parametric mapping can help. Now, we can even do this without contrast. If we just look at the native myocardial T1 times, this had the best sensitivity and specificity other than the ECV to be able to diagnose cardiac amyloid compared to either echo parameters or MRI parameters. And again, just another example of what it looks like. I can take patients with left ventricular hypertrophy. You might think it's hypertrophic cardiomyopathy, but I can differentiate, is this end-stage chronic kidney disease, hypertrophic cardiomyopathy, AL amyloid, or ATTR amyloid, simply by looking at the T1 map and the LG. It can give us a lot of information. Again, all these patients have left ventricular hypertrophy. In the old days, we might have said it's hypertrophic cardiomyopathy or hypertensive heart disease, but we can get much more nuanced now. This is a quick graphic of infiltrative heart cardiomyopathies and how the diagnosis was changed after cardiac MRI, after this non-invasive biopsy. This is a man with atrial fibrillation with severe LVH, thought to have hypertrophic cardiomyopathy, had T1 mapping that was low, diagnosed with Anderson-Fabry disease. A 39-year-old man with
Please, good news. Yes, it is started. It is working now.
Good.
So please resume your talk, Dr. Akhil, please.
Okay.
Okay.
Thank you.
Okay.
I was mentioning that in this case, it's a 39-year-old male with palpitations who had right ventricular dilation on echocardiogram. The presumptive diagnosis was arrhythmogenic right ventricular dysplasia. However, the patient was sent for an MRI, and the pattern of late ganglion enhancement really diagnosed cardiac sarcoid. So you can see with MRI, you can really change the diagnosis, prognosis, and management of patients. This is a 37-year-old male with sickle cell anemia. Restrictive cardiomyopathy was detected based on the transthoracic echocardiogram and Doppler signals with a dilated cardiomyopathy. However, when we did T2 star imaging, you can see that this was very low, in fact, diagnosing the patient with iron overload cardiomyopathy. And the fourth example is a 70-year-old male with pulmonary sarcoid. So you must think that this must be cardiac sarcoid. Well, after doing late ganglion enhancement, it was clear by the diffuse pattern of late ganglion enhancement, this was in fact a patient who had cardiac amyloid, not only pulmonary sarcoid, but cardiac amyloid. So very important to understand that the diagnosis can be changed after a cardiac MRI. Now, the last case, which I think will bring home the point, this is a patient I saw just a few months ago in the COVID era, 37-year-old male radiologist with no medical history, very healthy, in fact, of Indian descent, who came in with acute crushing chest pain. In the cath lab, his presenting EKG in the emergency department was an idioventricular rhythm, as you can see here. So very concerning story, perhaps for a reperfusion injury or a myocardial infarction, sent to the cath lab. So his blood pressure was a little bit low, but you can see the coronary arteries are completely normal. Absolutely no obstructive coronary arteries. Beautiful angiogram. A little bit of slow filling in the RCA, but I think it was a combination of catheter and also sleep pressure at the time. They also did a left ventriculogram. You can see here that there's perhaps some hypokinesis of the anterior and inferior walls, and the basal segments look a little bit better. So maybe it's a Takotsubo cardiomyopathy. So immediately I shifted the patient to the cardiac MRI scanner. You can see these images here show that the LV function is mildly reduced. The anterior inferior walls are maybe ballooning out a little bit. So I think this could be a stress cardiac MRI. However, when we looked at the T2 stir sequences, again, remember, these are sequences that look for edema. You can see from the apex, this is the apex, to the basal segment, there's significant hyperenhancement in the apical inferior segment, to the anterior segment, the mid-lateral wall, the mid-anterior wall, the mid-septal wall. You can see diffuse signal uptake suggestive of an inflammatory process going on. And again, this is a 4-chamber sequence showing all this inflammation within the septum. Now, looking at the MRI, incredibly impressive images, perhaps from the worst I've seen. This is diffuse subepicardial delayed enhancement in the basal to mid-anterolateral wall, the basal to apical anterior segments, and the inferior segment. This is a classic pattern for myocarditis. So this patient we diagnosed with myocarditis. Here are some more images that show the septal involvement, the subepicardial involvement. So classic for myocarditis. Now, in the COVID area, I thought this was COVID myocarditis. So I checked twice for antibodies and antigens. Those were negative. So this is presumptive viral myocarditis for this patient. So we did a Holter monitor. He had some short runs of NSVT. He underwent an EP study that was uninformative, and he was placed on metoprolol, lisinopril, and over 3 months, his ejection fraction has improved a little bit as well. So what's incredibly helpful with MRI is being able to diagnose myocarditis. This is the updated Lake Louise criteria that was published in 2018. Now, if we all remember from the previous criteria, which really didn't incorporate cardiac MRI, I think MRI has become front and center now for the diagnosis of myocarditis. And you can see here the main criteria for the diagnosis of myocarditis in patients with suspected myocarditis is MRI imaging. Of course, we'll check troponins and BNPs, inflammatory markers, but what we will look at is the evidence of myocardial edema with T2 mapping or T2 weighted sequences here. And then we will also look for non-ischemic myocardial injury, so either abnormal T1 times, extracellular volume, or the presence of late ganglion enhancement in a pattern that's suggestive for this. And then we can have some supporting criteria as well, either pericardial inflammation or systolic LV dysfunction. So our patient had myocardial edema, a non-ischemic myocardial injury, and systolic dysfunction, so we diagnosed him with myocarditis. Now, what's very important is myocarditis and cardiac MRI can be helpful for prognostication as well. These were 2 studies done in the past couple of years that looked at, one, the presence or absence of late ganglion enhancement. If you had late ganglion enhancement, you tended to do worse than patients who did not. That makes sense. These were 600 patients followed for 5 years. The presence of LG was associated with worse outcomes. Now, another study looked at where the late ganglion enhancement took place. This looked at 374 patients with acute myocarditis and normal ejection fraction. So if you had mid-myocardial late ganglion enhancement in the anterior septum, these patients did worse than patients with patterns of LGE in different areas of the heart. Our patient had LGE all over the place, and so probably will have a slightly worse prognosis. Thank God he's doing well at this point in time. So I know we've run over, so I'll finish up with the last slide. Cardiac MRI is much more than structure and function. I won't even talk much about ischemic heart disease today, but it really can be used as a non-invasive biopsy of the heart. And in many times, in fact, for patients, especially post-transplant, cardiac transplant patients, we are doing MRIs to be able to look for evidence of rejection after the first year or 2. But we can utilize things like T1 mapping, ECV, which is a marker of interstitial fibrosis, and fat content to see if there's diffuse inflammation or interstitial fibrosis. We can look at T2 mapping, late ganglion enhancement that looks at macroscopic fibrosis. We can use perfusion imaging and angiography as well. And this is useful for biopsying non-invasively cardiac masses or tumors. We can look at ischemic heart disease. We talked a little bit about determining if there's acute or chronic ischemia. We can predict the success of revascularization. And of course, we can look at infiltrative heart disease, amyloid, sarcoid, Anderson-Fabry disease, iron overload. We can diagnose hypertrophic cardiomyopathy, myocarditis, heart failure with preserved ejection fraction, and arrhythmias. And so with that, I will conclude. And thank you for everybody's patience while we had some technical difficulties.
Thank you, Dr. Akhil. I think we can have 4 minutes of discussion for the benefit of the delegates who could not actually participate in the discussion. 4 minutes. So the chairperson, maybe you have to repeat the same questions to Dr. Akhil. Dr. Akhil.
Dr. Akhil, we discussed a little bit earlier about the benefit of between CT and MRI. Is there now any role for CT except for looking at the coronary arteries? Because you said the pericardium was better seen, the myocardium is better seen, and so many other advantages you showed. So should we do CT at all for any of cardiac problems?
I think we touched on this a little bit earlier, but there will be a fraction of patients who cannot tolerate the scan because they're claustrophobic or they have contraindications. I think for valvular imaging prior to transcatheter therapies with a mitral valve, we do valve-in-valve therapies for TAVR imaging. For tricuspid valve imaging, I'll be giving a talk tomorrow on intervention of the tricuspid valve. CT is still going to be a mainstay therapy for that. So I think it's very helpful in those situations. And then at this point in time, as we all know, MRI is something that is a contraindication to patients who have a balloon pump and who are sick, and CT scans can be done for those patients. And so I think CT scan will never go away. I think in many ways they're complementary modalities. I use them both clinically. I read them both clinically in addition to echo. And so some patients will benefit from MRIs when it comes to tissue characterizations. I think the coronary disease anatomy, for a lot of valve interventions, the CT still will be mainstay for that.
How about patients who have devices? What is your wideband MRI? Can you, I mean, you can do an MRI, but are you able to characterize the tissue so well despite the artifacts?
Yeah, great question. That's an emerging area right now. So at our center, we are actually doing T1 imaging and T2 imaging in patients with wideband protocols with patients who have intracardiac devices, ICDs or pacemakers. It depends obviously where the device is located. Closer to the heart will produce more artifact. A little bit further away to the heart, if you lift the left arm where if the device is in the left pocket, then you can actually move the ICD out of the way a little bit. So I think there's a lot of promise for it. And I have had multiple patients now, similar to what I presented earlier, who've had an ICD or pacemaker implanted, perhaps for the diagnosis of ventricular tachycardia. And then they come and get an MRI afterwards, and we diagnose them with hypertrophic cardiomyopathy or cardiac sarcoid or something like that. So I think in the right center with experience, the wideband protocol, you can still do a lot of parametric mapping to be able to characterize the tissue.
Any point about the gadolinium nephrotoxicity? Is there any issue because we can't do contrast CT in those situations? So would CKD patients, would you treat them differently with MRI gadolinium?
Yeah, absolutely. So, the newer gadolinium contrast agents actually now are able to be used in patients even with dialysis patients or those with CKD stage 4. There's been no reports of nephrogenic systemic sclerosis in those patients. And so we do use it occasionally in those patients. Now, the trade-off is patients with chronic kidney disease tend to have more interstitial fibrosis. So the late gadolinium enhancement, ECV, tends to be less helpful in those patients. But for instance, a patient who comes in with acute heart failure, has new acute kidney injury, and once they've stabilized and they have maybe LV dysfunction, I will get MRIs in those patients as well. And so we can absolutely use it on patients either even on dialysis for short term or even with CKD stage 4 because the reports of injury in patients with the newer contrast agents with gadolinium is nil.
Would you still do cardiac biopsy in any patient where MRI won't give the information, or is cardiac biopsy now completely taken over?
It's a good question. I think sometimes we still do it. In that patient that I showed you with myocarditis, he had some non-sustained ventricular tachycardia. And at first I was actually very interested, despite the MRI, to understand what was going on from a tissue level, histology level. So I sent him for a PET sarcoid that was negative for sarcoidosis. I was still worried about biopsy. And so we're still considering whether or not we should biopsy him. There was another patient who had diffuse elevated ECV recently and heart failure, completely unexplained heart failure. So I sent her for a biopsy just a couple of days ago to see what the myocardial tissue will look like under histology. So I think the suspicion for doing a biopsy can be increased by MRI. So I think there's a value in doing both, especially if the MRI shows there's some problems with the myocardium, but we don't know what it is.
Thank you, Dr. Akhil. I think we can move on to the next session. It's a debate, point counterpoint session, and I invite Dr. Prakash VS. Dr. Prakash, are you there?
Yeah. Can I share my slide?
Yes, please share your slides.
It's a pleasure to introduce Dr. V.S. Prakash, who is a senior professor at MS Ramaiah and of cardiology and electrophysiology. He'll be talking about the role of cardiac MRI before deciding whether it's CRT-D or CRT-P in an idiopathic cardiomyopathy, dilated cardiomyopathy. Prakash.
Thank you, respected Chairman, Dr. Narasimhan, for the kind introduction. Without taking much time, let me just say that yes, we are dealing with idiopathic dilated cardiomyopathy when we know we are dealing with something which it is not explained by abnormal loading conditions to hypertension, valvular coronary artery disease. All those are excluded. And if you look at the latest guidelines, what is the most important thing for implanting a device, a CRT or a CRTD, is the left bundle branch block with the white QRS, the most important indicator. So now looking at left bundle branch block induced cardiomyopathy, 2013, I think Valiant and colleagues defined what is LBBB-induced cardiomyopathy. They said sinus rhythm more than 5 years with typical LBBB, ejection fraction is starting with 50%, and then over a period of time, it starts worsening, increasing LV diastolic diameter, worsening of LV function, NYHA class, and mechanical dyssynchrony, so on and so forth. And this would be an indication for CRT with a super response to CRT. So that is LBBB induced cardiomyopathy. And there are red flags apart from the white QRS. Most important thing is you exclude all other diseases, reversible or coronary artery disease. You have dyssynchrony by echo, and a very important thing by CMR, tissue characterization is unremarkable. So we are looking at LBBB-induced cardiomyopathy where the tissue characterization is absolutely unremarkable. So there's no role for imaging. Oh my goodness. Have I revised my role? Am I a protagonist or an antagonist? I think probably we are sharing the same sword. Let me try and look at it again. But if you look at this strict criteria, what they really landed up was only 6 patients out of the 375 candidates who were for CRT had this classical criteria of LBBB cardiomyopathy. So obviously, what are we doing in the others? DCM and LBBB is a very complex association. Patients with DCM frequently present with prolonged QRS, maybe IVCD or LBBB. And if you look at some retrospective studies where they did 6 and 8 patients with DCM, LBBB was found in about 31% of cases. LBBB may appear at different times in the course of the disease. And if you look at DCM with LBBB, again, in a small study, they found that 21% of LBBB could be having DCM. So the kind of complex association between DCM and LBBB, as we understand, and it's not as simple as LBBB-induced cardiomyopathy, which is a very, very narrow spectrum of patients. So we are implanting patients with a CRT or a CRTD in a wide spectrum of cardiac myopathies with bundle branch block. This was just started the case study. 66-year-old female NYHA class 3 ECG showed LBBB white QRS, ejection fraction 32%, global LV hypokinesia, angiogram, CAG was normal, epicardial coronaries, implanted a CRT. She was stable, discharged 2 days later. This was our ECG starting, and then with the biventricular pacing, it narrowed down. A week later, she was found dead early in the morning. So what could have happened here? CRT interrogation showed ventricular fibrillation. So sudden cardiac death. So how do we predict this? There must be some kind of arrhythmogenic substrate, either a fibrosis or scar. So the best way to probably predict, as Dr. Akhil was telling us, LG, the non-invasive gold standard, identifies myocardial scar, and especially in the non-ischemic variety, you have a mid-myocardial scar or a subepicardial or a patch distribution. As you see here on the left-hand side is late gadolinium showing a mid-myocardial scar, whereas the other, an infarct with a transmural scar in an inferolateral location, differentiating ischemic from non-ischemic. So you look at CMR, LG negative, obviously you have the LBBB cardiomyopathy, genetic DCM and all that. But today our talk is confined to IDCM, where you have a mid-myocardial scar, unlike the large gamut of patients with IDCM who have a coronary distribution of scar. So the take-home message is patients with DCM and LGA have a higher risk of ventricular arrhythmias or sudden cardiac death. How was CMR going to predict the trajectory of a disease? If you look at this study done by Leah et al., they clearly said that those who had mid-myocardial disease or LG had fared as bad as the ischemic cardiomyopathies, unlike those who had LG negative. The cardiovascular mortality, the total mortality, everything was far, far, far less, and they did well compared to those who had LG positive. And another study, which was about 252 patients with DCM, they said that CRT would benefit patients who have LG positive versus CRTP only in those with LG negative. So, and the most important thing is those who have LG negative did much better with CRT. The response was much better, survival and response. And as Dr. Akhil did mention about the pre and post TI imaging, where if you're ruling out edema, obviously, if you have diffuse interstitial fibrosis, again, that forms an area for re-entry circuits and generation of tachycardias, and again, harbinger for sudden cardiac death. So again, in these kind of patients, you need to probably implant a CRTD versus a CRTP. It was just showing you the edema, and I think he had shown some beautiful pictures. And that's what this is a study by Wong et al., where they said that the ECV more than 28.5% was associated with all-cause mortality, much higher versus those who had normal ECV. Just trying to show you the same T1 imaging and increase in the extracellular volume. So prediction of left ventricular reverse modeling, again, if you're looking at left ventricular reverse modeling, most important factor is the LG. LG absence would reverse, you'll find them reversing, and especially even if their LV function is poor at starting, whereas those who have LG positive or who have extracellular volume, higher volume, would obviously will fare less better. So the gold standard of CMR technique for assessing myocardial motion and deforming is tagging. Probably this still needs standardization, which I'm sure Dr. Akhil would agree to. So this is probably we're still not able to clearly improve upon echocardiography in trying to bring about dyssynchrony and its ability to match the ability in CMR. So, but CMR seems to be doing much more. It gives you LV function. It tells you morphological assessment, tissue characterization, and all that. So obviously, I think that's the way to go in assessing a patient with dilated cardiomyopathy. So to conclude, I would say that cardiac MRI is an ideal non-invasive imaging technique which allows calculation of ejection fraction as well as tissue characterization with a late gadolinium contrast, parametric mapping, and feature tracking. And LG defects shows mid-myocardial fibrosis in at least 30% of DCM, those so-called IDCM. And meta-analysis did show an association between fibrosis and sudden cardiac death. And those without fibrosis did well with regard to sudden cardiac death. T1 is the other way. T1 mapping and extracellular volume calculation are again trying to define diffuse fibrosis. And last but not the least, CMR has several tools like strain and tagging, which offers incremental value over to improve strategization and also to guide us whether we need CRTD or CRTP in a given situation. And probably we're waiting for this study, which we are trying to compare CRTD versus CRTP
Next
in
speaker,
IDCM
please.
patients
Next
with
speaker,
heart
please.
failure and no LG.
Next speaker, please.
Yeah.
Thank you.
Ajay?
Yes, respected
Yours.
chairpersons, dear
Floor is
friends,
yours.
I'm sharing my slides. Thank you, Dr. V.S. Prakash, for an interesting talk, though I heard more about MRI for picking up patients who would respond to CRT rather than CRTP versus CRTD. And the first disclosure, I regularly use cardiac MRI in my evaluation of patients with dilated cardiomyopathy. But my recommendation for CRTP versus CRTD is not based only on CMR findings. So cardiac MRI for CRTP versus D in idiopathic dilated cardiomyopathy, are we there yet? I don't think so. First point is in secondary prevention. If the patient has had a VTVF or aborted SCA, ICD or CRTD should be implanted. What we are talking about is basically primary prevention. And only 20% of patients with dilated cardiomyopathy who have ICDs for primary prevention subsequently receive appropriate therapies from the devices. EF, as we know, has low sensitivity and specificity for prediction of sudden cardiac death. And the Danish trial questioned the benefit of primary prevention ICD in patients with non-ischemic heart failure. Dr. Narang just talked about the MR components, black blood, fast spin echo, MR images allow morphologic assessment of heart with high spatial resolution. T2 images we can look at a myocardial edema, T1 images for the diffuse fibrosis,
And when we use gadolinium contrast, we get a better idea of edema, infiltration, fibrosis. Now the question here is the role of fibrosis or scar, its correlation with ventricular arrhythmias, estimation of fibrosis or scar burden, qualitative versus quantitative, and interpretation of cardiac CMR with specialized software and the expertise. So these will determine whether we are going to the CRTP versus CRTD point. Not all patients with dilated cardiomyopathy have identifiable scarring. The LG on CMR imaging can detect areas of localized myocardial fibrosis. There have been several studies which analyze the association between LG and outcomes. However, with regard to arrhythmic events, these results have varied. And these were mainly single center studies, relatively small number of patients, where they have shown that EF has limited sensitivity and specificity for SCD prediction. Combination of LG and EF evaluation is promising, but the LG CMR protocols have to be standardized. And the real question in patients with severely depressed EF, a negative LG test, would you get around without giving an ICD in these patients? We are not so sure about that. So this was a meta-analysis of 29 studies, almost 3,000 patients. The association between LG and arrhythmic endpoint was significant among studies with mean LVF more than 35%. So these are not ordinarily CRT candidates. And LG was present in a variable proportion of patients with dilated cardiomyopathy ranging from 21 to 70%. Almost 44% of the patients had LG. Arrhythmic endpoint occurred in 350 patients, that's 12% of all. And of these 350, 272 had LG, but 78 without LG. So not having LG does not give a free ticket. The questions are whether patients with LG could benefit from primary prevention ICDs irrespective of their LVEF, and patients without LG might not need preventive ICDs despite having severe LV dysfunction. And to restrict the CRTP, restrict to CRTP if CRT criteria are satisfied. I don't think those questions have been answered yet. Moreover, there are problems with cardiac MR. The gating and imaging may not be optimal due to frequent PVCs, due to atrial fibrillation, arrhythmias. And we just talked about renal failure, gadolinium contrast could not be used till now because of the nephrosclerosis issue. Concerning issues from this meta-analysis that in patients with LVF more than 35%, the arrhythmic endpoint occurred in almost a third of patients and with LG, and almost 5.6% of patients without LG also. In studies with EF less than 35%, the arrhythmic endpoint occurred in 19 and 4%, those with and without LG. Most SCDs occur in patients without severely impaired LV function who are usually not protected by ICDs because they don't fall into the criteria for a primary prevention device. And these patients also would not be eligible for a CRT because their EF is better. In this analysis also it was found that there's no significant correlation between LG and LVEF. LVEF did not correlate with overall proportion of arrhythmic events. And when studies with mean EF of more than 35 or less than 35 were considered separately, there's no significant difference between them in terms of overall percentage of arrhythmic events or annual event rate. So we are still searching for clues here. Some patients without LG still experience the arrhythmic endpoint. There's another issue. Diffuse fibrosis is commonly found in patients with dilated cardiomyopathy, and they may be important substrate for VF. So, like Dr. Naran said, T1 mapping or extracellular volume fraction may help define fibrosis better, and those may provide clues. Finally, coming to the point of quantification of scar and fibrosis, there are major limitations to this. There are no definite quantification methods. Quasi-quantification by percentage of scar and fibrosis can be fallacious, and special software and algorithms to measure mass of scar or fibrotic tissue are still in research domain. They are not universally available. What is being done in form of quantification is quasi-quantification. The scar quantification is performed by an expert. The LV is divided into 16 segments, Each segment is given a score, 1 for no scar, 2 for less than 50% thickness, and 3 for more than 50% thickness of fibrosis or scar. And sum of all scores are then divided by 16, that is expressed as a percentage, and that gives a quasi quantification. So CMR imaging protocols need standardization. We need expertise in the form of MR being read by radiologist interested in cardiac MR and a cardiologist who has to be involved in interpretation of the cardiac MR. So we just had the discussion in the panel that we need to have a unifying form of imaging experts in this. So summarizing my points, significant arrhythmia risk in patients with EF more than 35% is there in this population. This is not even a traditional CRT population. So we need to identify these patients better. We know that in our clinical experience that patients who respond to CRT have a lower rate of arrhythmic events. We need to have true quantification of scar or fibrosis, especially by mass. There is need for standardized protocols, need for interpretation expertise. So when we talk about CRTP versus CRTD in non-ischemic cardiomyopathy with no or low LG and fibrosis, such a strategy is hypothesis generating, and it should evaluate it in future studies. So are we there yet? I don't think so. Thank you.
Thank you, Ajay. There is an interesting debate between the two. To people who are listening to this lecture, this is not an esoteric or a theoretical problem, because there are several patients in our country who can barely kind of afford pull up the resources for a CRTP, but they may not have the resources for CRTD because it's almost another 100% increase in the cost. So this is not a moot point that we are discussing. We need to kind of see how to optimize our therapy in a person who has got limited resources. If you're in a Western world, this is probably theoretical because the insurance will cover and you just put in a CRTD for all these patients with LBBB and heart failure. So we had two interesting points of view. I would like to take the inputs from my co-chairs as well as anything from the delegate, any questions in the chat box, and then we'll have a rebuttal from Dr. V.S. Prakash. Akhil, are you there? I hope you understood.
Yeah, I'm here.
Yeah, the scenario here is there are a lot of patients in India who benefit from a device but who cannot afford a CRTD. They may just about pool their resources and go in for a CRTP.
Yeah.
And that is when MRI becomes very relevant. It's not a theoretical discussion anymore.
Yeah, absolutely. I think, when it comes to resource allocation, it becomes much more complicated. In a perfect world, we will be able to understand what the patient needs and get it to them, but it's certainly not possible. Even in Western countries, it can be a challenge as well. The one comment I would have is, when possible, I think a baseline evaluation with an MRI for patients either with arrhythmia or cardiomyopathies can be very helpful, because it allows them for a single point in time that can be compared to in the future. So let's say someone has a pattern of scar that potentially makes you concerned, but not enough to be able to do a CRTP, perhaps because of finances or something else. Well, if things change over time, and you're able to get more information 2-3 years later that shows more extensive scars that allows for an upgrade of the device, that's something that can be done potentially as well. So I think in these situations, at least having some data is probably better than having no data.
Great. See, certain other things are elevated NT-proBNP. Fractionation of a QRS is a poor man's MRI. So you see intrinsic high-frequency deflection within the QRS. That's a poor man's equivalent of picking up a scar on MRI. And we pool all these resources when we make a clinical decision. I think we had a wonderful session. I think, Dr. Jeevar, we are coming to the end of the session.
Thank you.
Dr. Dalal, Dr. Bhupesh, any
Thank you. I think Dr. Narasimhan, I think we are running short of time. Can we
Okay,
ask
I
you
understand.
to?
Thank you very much.
Yeah,
And I
because
would
of
like to
technical glitches,
congratulate,
I'm very sorry. We am very
yeah,
sorry
that's fine.
because.
Thank you very much
Thank you so much.
for
Good night. Have a
Akhil and
great
all
day.
my colleagues. Thank you very much. We'll end the session
Thank you.
here. Thank you
Thank you
so
so
much.
much. Thank you so much. Yeah, Dr. Wander is there. Dr. Wander, can you unmute yourself?
Yes, sir.
Yeah, Dr. Rakesh. Rakesh Gopal. The chairpersons are there. It's a very, very important international session. We have 2 pre-recorded sessions and then 3 other things are not recorded. So, because there is some time delay that we had, but let's go to the first session. That is probably Dr. Bernard Gerst's pre-recorded talk. Can we have the pre-recorded talk by Dr. Gersh?
We are playing, sir.
Yeah. I do not know whether Dr. Gersh will be there for the discussion, but let's see the recorded talk, please. Dr. Warner, can you hear me now?
Yes, very nicely.
Okay. Rakesh, can you hear me?
Yeah, I can hear you very well, sir.
Yeah. Thank you.
Good evening. It's a great pleasure to be here at the CEO, to be part of the CSI meeting. I wish I was there in person, but thank you for inviting me. My first talk is going to be on the role of ischemia in sudden cardiac death and the implications that this has for the ICD and for coronary revascularization in secondary prevention. In other words, how do we approach people who have experienced an out-of-hospital cardiac arrest and have been revascularized, but do we need an ICD or not? So this is the classic arrhythmia triangle developed by Dr. Philippe Coumel in France about 30 years ago. You have a substrate, modulating factors, and triggers, and all these 3 interact to cause sustained ventricular arrhythmias. The substrate can be ischemia or scar fibrosis, left ventricular hypertrophy. Triggers are PVCs or premature electrical stimuli at the time of an EP study, and modulating factors, autonomic nervous system, and electrolytes. Now, the evidence implicating ischemia and sudden cardiac death is extensive. We have epidemiological data, pathologic and angiographic anatomical data, ambulatory monitoring and stress testing that have shown that periods of ischemia coexist with, are associated with ventricular arrhythmias. We've got data from the EP lab, and then data from pharmacologic and surgical therapies. So there is absolutely no question that ischemia can cause sudden cardiac death. The question and the concern is that anti-ischemic therapy reduces the risk of sudden cardiac death, but it does not eliminate it. So will anti-ischemic therapy alone be sufficient in a patient who's had an out-of-hospital cardiac arrest due to a coronary occlusion, which is now being reperfused? Is that enough? And that's the key question. Now, this study of ARBs and ACE inhibitors from Dr. Solomon, the Valiant trial, if you look at the risk of sudden cardiac death stratified by ejection fraction, it makes a very strong point, and that is the highest risk of sudden cardiac death is in the first 1 to 2 months post-infarction. So when we first saw this trial, one of the issues that came up was, should we be putting defibrillators into these patients before they leave hospital? And there were a number of trials of ICDs for primary prevention. Everything below the line shows a benefit for the ICD. These are the earlier trials, MADE-2, SCUD-HEFT, MUST trial. But there were 2 trials that did not show a benefit for an ICD implanted very early on before discharge. The Dynamite trial and the IRIS trial from both, I think, were from Germany, but IRIS certainly was. And the Cabbage Patch trial, which was a trial of defibrillator patches being placed at the time of bypass surgery. But those were the two that raised a lot of questions. And then in the dynamite trials, there was a very interesting observation presented in 2004, but actually only published in 2010. And that is that if you look at people who got an ICD versus no ICD, there was no difference in overall mortality, but arrhythmic death was strikingly reduced by the ICD. But then why not an effect on mortality? And then that was explained by this, which is one of the most unusual observations I think I've ever really seen. I understand it now, but I didn't understand it at the time. Here's the risk of death in control patients without an ICD. ICD no shocks, and ICD shocks. So if you received shocks from the ICD, the cumulative risk of death was that much greater in a trial where the overall mortality didn't change. This is pretty difficult to understand. And the group at the increased risk of non-arrhythmic death were those who got ICD shocks, appropriate shocks. Just think about that for a moment. I don't know if you've ever seen that quote. If you're not confused by this, then you're not thinking clearly. So you have a reduction in arrhythmic death, but in those who had appropriate ICD shocks, they had an increased risk of non-arrhythmic death. Confusing. Well, I think the answer comes from this trial again and from another autopsy study from Denmark. If you look at patients who died a sudden unexpected death in the first month after myocardial infarction, the vast majority had acute recurrent infarction or rupture. When you get out beyond 3 months, the majority of sudden unexpected deaths are presumed arrhythmic. And between 1 and 3 months, it's again a higher rate of presumed arrhythmic deaths. So how do I explain all of that? Well, I think it's like this, or at least this is an explanation we put forward in a study, a paper published years ago. In patients with MI and LV dysfunction, particularly if they've had a recent infarct, early mortality, in patients with a recent infarct and LV dysfunction, early mortality is due to recurrent MI, cardiac rupture, and heart failure. Ventricular arrhythmias in these patients are simply a surrogate of these other processes. Remember, many things can cause ventricular arrhythmias, and it may not be a primary arrhythmic event. It's a surrogate of these other events. And here you will get appropriate shocks from the ICD, but it will not have a mortality benefit. And in fact, the group at the highest risk of non-arrhythmic death had the most number of shocks. Late mortality after 3 months or 6 months is due to remodeling, both anatomic, ionic, and neuronal, compensated heart failure, and now the events that cause sudden unexpected death are true arrhythmic events. And this is where you get a mortality benefit from the ICD. What we're starting to see is a whole different spectrum. And these are people now who are 15 years out, 20 years out from an MI and ICD implantation. And what we're seeing is end-stage disease with recurrent shocks that probably do not change the prognosis. But in the intermediate term, 5 to 15 years, the ICD has had a huge benefit in these patients, but I now think I can understand why it doesn't have a benefit in those within the first 3 months. Question: do you have to place an ICD in everybody who's had an out-of-hospital arrest and is revascularized? Well, I don't think it's necessary in all patients. If you had a patient with single vessel disease and a clear culprit lesion, and they had acute ischemia, and you revascularize, do you have to place an ICD? I don't think so. But then that's the minority of patients. The vast majority who have survived a cardiac arrest, you've got to remember that the coronary disease is progressive and dynamic. There is a genetic substrate that I'll illustrate for acute ischemia-induced arrhythmias. There's a group of people who, when they get ischemia, fibrillate. There's another group of people who, when they get ischemia, they have an MI and they don't fibrillate. So this substrate for ischemia-induced arrhythmias, if they presented with a cardiac arrest the first time, they may present with a cardiac arrest the second time when a disease is progressive. And they still have a substrate. Many people who've had an MI still have SCAR, which is a reentrant arrhythmia substrate. So ICDs are indicated for the vast majority. What evidence do we have? 58 sudden cardiac death survivors who underwent bypass surgery all had ICDs. These are old papers. This is 1994. And if you look at patients who were non-inducible at the time of discharge, non-inducible, and how many had appropriate shocks subsequently? 40%. So non-inducibility meant nothing in this patient population. This study is an interesting one from Goldberg, and he looked at patients enrolled in the MADED-2 trial who had ICDs versus conventional therapy. And if it happened that they had early coronary revascularization within 6 months of enrollment, you could see that at 2 years there was no difference between ICD and conventional. But if you go to patients who'd had been revascularized 7 to 12 months earlier, you see they are protected for a period of time by revascularization, but then that falls away. The protective shield is temporary, and that group have a long-term benefit from ICDs. And then if you look at those who were revascularized sometime in the past, 5 years or so before entering into the MADED trial, what you see is they're not protected at all. And very early on, there is a benefit of an ICD. So I think this is a quite striking evidence that simply revascularizing someone does not protect them unless it's a single vessel with an acute culprit lesion, thrombus, and you reperfuse. This is a study we did of 114 survivors of a VF out-of-hospital arrest, either due to acute myocardial infarction or acute ischemia with angiographic evidence of a significant stenosis. 45 patients had an ICD, which reflects the uncertainty about what to do in these patients, at least at that time. And this was 2015. And what you can see is over time, we tended to put in more and more ICDs in people who'd had an out-of-hospital cardiac arrest secondary to an ACS. But certainly by no means all of them. This is interesting and sobering. In the 45 patients who had an ICD, 42% of total patients, this is the time to the first appropriate shock. And not surprisingly, in those with an ejection fraction of less than 35%, about 65, 70% had appropriate shocks. But this is of concern. Even if the EF was greater than 35%, at least within the first year or two, they did have appropriate shocks, which really points to the fact that, again, many of these patients who would have been revascularized are not completely protected. And the adjusted mortality with an ICD implant was substantially reduced, hazard ratio of 0.24. All-cause mortality, just a trend, 0.059. This is another study from our group using Olmsted County data. And what we show is that in patients after a myocardial infarction, recurrent ischemic events and heart failure are extremely common. And these in turn, I think, are responsible to a large extent for recurrent, for sudden cardiac death. And on a multivariable predictor of sudden cardiac death, we found that the presence of heart failure very powerful and a trend not quite significant for recurrent ischemic events. So here again, if you have revascularized at this point in time, that may not help you when you develop recurrent events, ischemic or heart failure, and again argues for an ICD. This is what I was referring to earlier, a very interesting study from France. About 8,000 men, I think over the age 43 to 52, who did not have ischemic heart disease upon entry into the study. Now, if they had a history of sudden cardiac death in one parent, their likelihood of experiencing a sudden cardiac death over the period of follow-up was 18.6%. This should be patient percent, not numbers. If their parent died of a myocardial infarction, but not a sudden cardiac death, they were then 9.9% more likely, 9.9% of patients were more likely to die of a myocardial infarction. And the point I'm making is it's probably the same lesion that causes either sudden cardiac death or death due to MI, namely a ruptured plaque. And some people have a genetic predisposition to respond by fibrillation, and others death due to myocardial infarction. And so if you look at the relative risks on multivariate analysis, if the one parent had a history of sudden cardiac death, 1.8-fold increase in sudden cardiac death in their male offspring. And if both parents had died suddenly, relative risk 9.44. But if they had a parental history of MI, they were not likely to get a sudden death, but they were much more likely to get a fatal myocardial infarction. And this is really very important, because what I want to say is that one of the reasons to put in an ICD in someone with coronary disease is it is a progressive disease. And if they initially presented with an out-of-hospital arrest, when they develop progressive disease and another ischemic event, it could result in the same endpoint, namely sudden cardiac death or out-of-hospital arrest. Finally, another old paper, but small, but very definitive. This was 23 patients, sudden cardiac death survivors, who had unstable angina or ischemia on stress testing. They were successfully revascularized. They were non-inducible at the time of discharge, followed up for 34 days. 23 patients. How many got shocks? 43%. And in on an average, eight patients had 1 to 22 shocks, with syncope and pre-syncope in 9, suggesting that these shocks were all appropriate. Small study, but I would have thought that if it really makes a point. I mean, they did have acute ischemia, they were revascularized, they were non-inducible, but it was of no predictive value. So to conclude, the role of ischemic therapy, the role of anti-ischemic therapy and coronary revascularization in the prevention of sudden cardiac death. For primary prevention, anti-ischemic therapy is effective in reducing incidence. We learned that from the beta blocker trials. The rate of sudden cardiac death was reduced. For secondary prevention, in survivors of VTVF, I think all should go to angiography. The timing of angiography we can discuss. Revascularization is very frequent. Revascularization alone is very rare in our practice. It's done, but it's rare. And then we have these trials of ICDs versus drugs that demonstrate the effectiveness of the ICD. And thank you for your attention.
Thank you, Dr. Gersh, for an excellent presentation. As it's a recorded version. Any questions? If he's joining with us later, then we can ask questions to him in the end. So, Dr. Vanda, with your permission, can we go to the next talk, please, Dr. Rakesh?
Sure,
Yeah,
sir.
yeah. Next talk is by Dr. Peter Lin. May I invite Professor Lin for his talk? He'll be talking on managing CVD patient primary to secondary prevention. Dr. Lin, please.
Great. Thank you very much. You can see my slides and you can hear me okay?
Yeah.
Okay, very good.
Yeah,
Thank you
audible,
very much
visible,
for the
very
invitation.
clearly. Yeah.
Very good. Thank you very much for the invitation. And you can see that I'm in Toronto. This is the cold weather that we're facing right now. So protecting your patients is like protecting them against falling off of this mountain, making sure that they have all the safety lines. And basically, these are my conflict of interest. I've worked with these companies in education. I don't do any clinical trials anymore. I thought I'd start with this funny. Are you going to get vaccinated with the COVID-19? And the other one says, no, you're crazy. They haven't finished the human trial. So hopefully we'll have more safety data on this. And I think COVID-19 has changed our assessment of risk. Suddenly you can be very well, and then you can be very ill within a matter of days with COVID-19. And so therefore our other diseases are actually much easier to manage. So if you look at lipids and hypertension and cardiovascular disease, we have a longer time frame of window in which we can actually help our patients, whereas COVID-19, it's been compressed. And so therefore the thought is that perhaps we can do better with our other chronic diseases in comparison to COVID-19. So how do we manage those patients better as we move forward? We often wait until there's an event. Many situations, the way we understood stroke and heart attacks was after the patient had an event. And as you remember, in the olden days, we treated our heart attack patients with morphine just to take away the pain. And we told them to basically don't move around. And that was our management of the disease. But as we understood the pathophysiology of it, we started realizing that there are many things that we could do in order to prevent those things from occurring. So you guys know about the risk factors, which basically we learned them from and we're trying to prevent the second one from occurring. And primary prevention are the patients that have not had an event yet. Now, traditionally, we separated these patients in terms of clinical trials. So in all of our lipids and many of our hypertension trials, we separated them into secondary and primary prevention type studies because the risk profile of these people and these people are quite different. As you've seen with the SGLT2 inhibitors and GLP-1 studies, the newer ones, we have a tendency to sometimes mix these patients in there. So it makes it a little bit more difficult because the primary prevention patients may not have as many events and they have different types of events. So we're starting to see that, for example, SGLT2 inhibitors in secondary prevention may prevent death and maybe strokes and heart attacks. But in primary prevention, it may prevent heart failure and renal failure. So the things that we can protect in our patients may be different depending on the risk category that they're in. But if you look at this basically summarizes the pathophysiology of all cardiovascular disease. So you have a blood vessel wall that's being damaged by hypertension. So as the hypertension damages the wall becomes injured. And so now you can actually have cholesterol particles getting into the wall. So LDL particles can now accumulate inside this area. And those particles were meant to stay in the lumen, but once you collect it in here, the only way to get out is macrophages come in and they eat them. And when they eat them, they become foam cells, and these foam cells continue to grow. And every so often, the macrophages will release their enzymes, which then begins plaque digestion. And so if you have plaque digestion, then you might have a small rupture, and then you form a blood clot. And then if the blood clot is small, then all you'll do is grow the plaque. But if the blood clot is large, then basically you have an acute event, either acute stroke or acute coronary syndrome that we're looking at. Recently, with all the studies coming out, we're saying that glucose medications may be beneficial. It might not be that controlling sugar is causing all those good cardiovascular benefits, but it may be the type of medications that we're using. SGLT2 inhibitors, we now know, have some benefits that are measurable in a short amount of time, 3 to 5 years. And the same thing with GLP-1 agonists also have measurable benefits in cardiovascular and renal in terms of a small duration of time of 3 to 5 years. And then finally, of course, the inflammation. So we know about these anti-inflammatory agents that we have, expensive, but study was positive that if you reduce inflammation, the thought is that the plaque would maybe less active and less likely to rupture. And so therefore, inflammation becomes an important role. And we now know that the COVID-19 virus causes a large amount of inflammation and therefore causes a lot of cardiac damage in that fashion. So we're now keenly looking at these anti-inflammatory effects. We know that statins will reduce inflammation. We know that increase burnt foods, like the fried foods and everything else can increase inflammation. And we now, of course, know that infections can increase inflammation. So that's why after flu season, we normally see an increase in terms of the number of cardiovascular events. And with COVID-19, it's been very clear that an infection can increase inflammation and therefore cause more events to happen. So therefore, vaccination may be a way to get rid of some of these conditions by getting rid of the inflammation that happens. For the few minutes that I have with you, I'm just going to talk about cholesterol in particular. And you guys know this story very well. We've done the primary and the secondary prevention trials. And if you collect them all together, and if you look at all of the studies together, as the LDL comes down, basically your event rates come down. If you look at primary prevention patients, it's the same idea, except the line is different. In other words, primary prevention patients, they have less events. Secondary prevention patients have more events. So the slope of the line is quite different. And it's important because if we use a drug like pravastatin, for example, you can lower the cholesterol by 25% and you will have a detectable benefit in a secondary prevention trial. However, if you take this kind of medication here in primary prevention patients, it's still a 25% reduction, but then the event rates will not be high enough to be significant. And so we would conclude that these drugs may not work in primary prevention. So that means in less sick people, you actually have to push the parameter much further in order to have the benefit to be measurable in a clinical trial. So that's why when some people say, well, this thing works in secondary prevention, therefore it must work in primary prevention, it may not be the case that you could prove it. And so that's why secondary prevention and primary prevention stick with the trials that looked at your patient population and use those medications appropriately. So in terms of the statin trials, basically, you know that statins is originally looked at as an antibiotic. So people were studying antibiotics, and it turns out that basically fungus can release a statin, and the statin goes towards the bacteria and blocks the cholesterol production in the bacteria, and therefore keeps the bacteria away. So it was a terrible antibiotic, but it was very good to control our lipids. And so we started off with patients that had known cardiovascular disease initially, and then we had a huge population that were in the primary prevention state that we had to address. And so we kept going down further and further in terms of lower risk, in terms of not events yet, but in terms of higher risk type of cardiovascular patient. And the lowest risk study that they did was the Jupiter study, where they basically looked at people that did not have high cholesterol, did not have any cardiovascular events, but did have a slight increase in CRP, so a slight increase in inflammation. And they were able to show that there was benefit of 44% reduction in the primary outcome. And the study was actually stopped early at 1.9 years because this result crossed all of the safety parameters. And so therefore they stopped the study. And in terms of the p-value, it's actually very long. So therefore, if you did this study in 100 million times, one time you'll get a different result. If you look at the breakdown of the primary outcome and you separate them out into the components of MI, stroke, revascularization, angina, and death, if you looked at all of these things separately, you could see significant, significant, significant. The only one that wasn't significant was angina. Total death was significant, and you have to stop the study when there's a death benefit. It's not allowed to keep the study ongoing, so therefore they had to stop the trial at that point. So therefore, Jupiter study looked at this lower risk population, and the purpose was to avoid more little baby studies along the way. However, people didn't like the idea of treating every single person, at low risk in terms of with a statin therapy. So people said, what about the intermediate risk group of people? Because we can all understand that they have high risk. And so therefore, the HOPE-3 study was designed, and Salim Youssef headed that, looking at giving statin therapy to these people. In the Jupiter study, there was this HRCRP, which nobody really liked. So therefore, here in HOPE-3, there was no measurement of inflammation. It was just give the drug and go. People didn't like 20 milligrams of rosuvastatin. So in HOPE-3, they said, let's use 10 milligrams rosuvastatin. And so what did they find if you just give it to intermediate risk patients? No monitoring, no titration, no CRPs. If you look at the primary outcome of CV death, MI, and stroke, it was reduced. If you look at stroke alone, it was reduced. If you look at MI alone, it was reduced. And if you look at revascularization, it was reduced as well. And this trial was 5 years in duration, and there was no difference in the diabetes rates either between these two groups, which means that if you separate out patients appropriately, in other words, they actually randomize people based on BMI and based on waist circumference. If you separate people appropriately, then the risk of increasing diabetes is actually not there. So over a 5-year period, there was no difference in the incidence of diabetes. If you look at the IMPROVE-IT study of ezetimibe on top of a statin, so you could see here that basically it was simvastatin was the base therapy, and then the ezetimibe plus simvastatin, you could see that there is a 2% reduction. So in terms of absolute difference is a 2% between the two, but you can see that we need another 1/3 of patients to have an event before you can actually see that 2%. And you actually have to wait 7 years. So therefore the thought of ezetimibe on top of a statin actually takes quite a long time to show benefit. And to get this 2% benefit, you actually have to have a lot more events happen before you can see that benefit. So that's why the Fourier study looking at PCSK9 inhibitors was of some interest. So this is the placebo group, which basically means high intensity statin group. So if you want to think of it this way, this is the intense treatment arm of the TNT trial. So this is the best treated on statin therapy. And then what happens is that they added in evolocumab, which, as you know, is a PCSK9 inhibitor. And you can see that there's a drop in event rates. And again, you see this 2% reduction. But you'll notice here, we only need about 10% of the patients to have an event here, 8% of the patients here. So we don't need 1/3 of the patients to have events to show a 2% benefit that we're seeing there. By the way, this one was 36 months. So that means within a 3-year time frame, you can get that 2% absolute. And the reason why we like 2% is because 2% divided into 100 would mean number needed to treat of only 50. So therefore, it becomes cost effective in looking at these. We also heard about icosapent-ethyl, which is the IPE, which is the omega-3, the purified version. So it got rid of the DHA. So we now understand that perhaps EPA is good, but DHA may not be so good. And so IPE is a version of EPA, but it's been modified a little bit. So this is a purified, highly potent version of things. And you can see here that the patients that took IPE had about a 5% absolute risk reduction. So number needed to treat is about 20 over a 5-year period. So if you added this on top of statin therapy and everything else, you could see the 5-point MACE and everything else, 25% relative risk reduction with a good p-value. And you could see here that the same thing, if you repeated the study 100 million times, you would get one difference. The absolute risk reduction is 4.8%, and they took that one right here at the 5-year mark. And so you can see number needed to treat is 21. So therefore, we can actually do better on top of our statin therapy as well for some of our patients. Unfortunately, it's not cheap. It's expensive. Both the PCSK9 and icosapent-ethyl are expensive agents. Now, in the REDUCE-IT study, they said, is it the IPE or is it some lipids that are changing? So if you look at the triglycerides, there is a slight reduction in triglycerides, but not a lot. If you look at the LDL, it's very minimal reduction in LDL. If you look at the non-HDL, very little reduction, and the HDL itself didn't really change much at all. So none of these things could explain that big 5% absolute difference. If you look at ApoB, there was very little change. CRP, there was a big significant change there. And if you look at the log of CRP, again, that one was significant. But the really significant one was the EPA level. So if you look at the EPA levels, you can see how high it is. So therefore, people are thinking it's the EPA level. And if you stratify patients based on EPA levels, it's actually the people that have the highest EPA levels are the ones that have the least events. So perhaps it's the actual molecule itself that's stabilizing membranes or whatever that may be giving the benefit. And in question period, we can talk about the necrotic plaque. So it seems like the people that had the high dosing EPA had less necrotic component of the cholesterol plaque. So therefore, the plaque is perhaps less likely to rupture. And maybe that's why we're seeing those nice reductions. So if we look at this in terms of the tiers, we have statin therapy as your baseline therapy. And so therefore, we have to make sure that that's a good one. Ezetimibe could be thought of adding on, but it takes a very long time to get that 2% benefit. And you have to have too many people having more events. PCSK9 inhibitor are good. They can give you that 2% benefit in a 3-year period, but the cost is quite high. And then, of course, icosapent-ethyl can also give you good benefit over a 5-year period, but again, the cost is quite high. But if you think about it, it's always the baseline therapy is statin. So which one should we be using? Because we can only pick one, and so which one should we use? And each company will show you that theirs is better. So instead of using company data, why don't we compare these statins in a governmental database? So therefore we get rid of any potential bias. And so if you look at the Netherlands database of 76,000 people, and they're looking at people staying well as being the good event, and then event rates coming down here is bad, you could see that this one is pravastatin, this one is simvastatin, this one is atorvastatin, and the one with the best rate is rosuvastatin according to the Netherlands database. In Canada, they did a safety study looking at rosuvastatin and other statins, so about 25,000 people. And what they found was that the safety was quite good. The study authors were trying to show that this caused more rhabdomyolysis, and you could see that there's no difference in the side effects, but they did see less death in the case of rosuvastatin and less cardiovascular death. And in Canada, most of the statins we use is atorvastatin. So that means this database is saying rosuvastatin versus atorvastatin, there is a death reduction in that big database. In the UK, the same group did the same thing with rosuvastatin versus other statins, but now the numbers are much bigger, no side effect differential, but again, the death rates were different. And there in the UK, the other statins is mainly atorvastatin or simvastatin. So that means that rosuvastatin versus these ones have less death as well in that big, huge database as well. Now that database was so large, they could break it down into each drug itself. And you could see that there is a reduction in total death and in CV death as you head towards the newer statin therapies here, and CV death, the same thing as well. So therefore, the newer statins, like the new iPhones, seem to do better in terms of reducing death in these databases that are sort of at arm's length from pharma. And so therefore, I show you this last picture. Basically, it's make sure you have good foundation. So therefore, no matter what you're considering, PCSK9 inhibitor, ezetimibe, or icosapentaethyl, basically make sure that your statin therapy is good baseline therapy, because A, it's the most economical one, and B, if we have a good statin at the bottom, then you can just build on top and give your patients even more benefit. Thank you very much for staying awake, and thank you for your time.
Thank you. Thank you, Dr. Lin. Dr. Bonder, Dr. Rakesh, any questions to Dr. Lin?
That was a lovely talk, Dr. Lin, and how you summarized the data and how to interpret. What is a high-dose rosuvastatin therapy according to you? Would you be guided by 20 milligrams, 40 milligrams, or lipid LDL levels? What would be your clinical approach in terms of making this foundation, and then you build up over it with other agents?
Yeah, I think most places, most countries, the 20 milligrams would be considered high dose. So a 20 milligram atorvastatin has the same lipid lowering age effect as about 80 milligrams of atorvastatin. However, there were some small Korean studies looking at ACS where they used 40 milligrams, and that was successful. Above 40 milligrams, at 80 milligrams of atorvastatin, then the side effect increases. So that's why there is no 80 milligram dosing of it. But most people at 20 milligrams, it's sufficient in terms of being the high dose. And that's the equivalent of about 80 milligrams of atorvastatin. The big difference between the two is the side effect is lower with the rosuvastatin. So there's less liver and less renal complications if you're using that. So that's why some people now sort of switch to the newer agents, I guess, if you will. Whereas if you use, let's say, simvastatin and you push to 80 milligrams, then the side effect profile is really quite bad. So each newer agent has the better side effect profile for that LDL drop.
So we in India actually are quite conscious of cost, and as we increase the cost goes up. So that's a significant issue. But do you see in Canada and in UK, this data that you showed actually is a little bit interesting, because this is a question which is posed so often. People will be switching over for rosuvastatin from atorvastatin, because even in our country, atorvastatin is the statin which is common, simply because it came earlier and we had the largest data with this.
Yeah, so we're starting to see people saying, well, do I want to go to a PCSK9, ezetimibe, or icosapentaethyl? So now I've increased the cost if I have to add one of those drugs. So that's why you're seeing many people saying, well, can I move to a more efficacious statin? And then if I hit target, then I'm great. And if I do need to add on top, at least I'm on the statin that will give us the best in terms of LDL reduction. And I think that's why people are saying maybe we should switch to the most potent statin. And then that way you can make a true decision. Do I need to add the second layer of medication? Because the second layer of medications are all quite expensive. So if I can get some benefit with my statin therapy, then why don't I just get the most benefit that we can from the statins before we have to add these more expensive therapies?
Dr. Rakesh, you have a question, or I have one more question to Dr. Lin. Actually, I'm just tempted to ask you. So a high dose statin, rosuvastatin to you would be 20 milligrams, but would that be the dose for an acute coronary syndrome patient also, or would you start with, I mean, what would be your approach?
Yeah, so there was a beautiful study where they gave 40 milligrams of rosuvastatin right away at the time of the ACS, and they noticed that out to 1 month and then thereafter, there was always a benefit. So the only difference was that one tablet of 40 milligrams. The LDL didn't drop that much. So the thought is that the 40 milligrams may have had an anti-inflammatory component, and therefore during the time of the stenting and the ACS, that anti-inflammatory component would be helpful. Unfortunately, we don't have big studies in the ACS population because once you've established that statin therapy is good for ACS, you cannot do a placebo-controlled trial. And so therefore you would have to have a statin versus another statin. And as you know, those studies now become bigger. You have to have more numbers of people before you can show a benefit of one versus the other. And that's why the appetite to do head-to-head trials is quite minimal. And that's why we do things like we look at the database from the governments. We look at network meta-analysis where we take the placebos and tie them together, and then we can compare the efficacy of these drugs to each other. But I think the best way is just to look at, the government data of all the people that are taking rosuvastatin, atorvastatin, simvastatin, who's doing better. And then that way that will guide us sort of in an unbiased fashion as to which molecule maybe we should be using.
Well, thank you. That quite well summarizes actually. Do we have time for one more question from Dr. Peter Lin? You spoke about the SGLT2 inhibitors. You were tending to mention those. We all started using it in heart failure patients. But how about high-risk coronary patients? Is there what percentage of your patients post myocardial infarction, high-risk patients with diabetes? What is the kind of usage of SGLT from the data that we have?
Yeah, I must admit when the EMPA-REG came out and DECLARE came out and CANVAS study came out, the cardiologists did not move on to the SGLT2 inhibitor. When the heart failure data came out, I think everybody moved because the heart failure data was very convincing, very short duration of time, the number needed to treat is low. It's in the ballpark in terms of cardiovascular death. For example, DAPA-HF, the cardiovascular death benefit of 18% reduction is very much in line with Entresto, So here you're getting the same benefit of an ARNI, but then you're doing it with a drug that's relatively cheap and the side effect is not bad and you don't have to stop the ACE inhibitor. So it was much easier to use. So I think after the heart failure data came out, I think many cardiologists started to jump onto the bandwagon. But then now when we look back at the data for atherosclerotic cardiovascular disease, we have very good data that the SGLT2 inhibitors will be helpful for them as well. So now we're seeing people moving across to the post-MI patient, post-stroke patient in terms of getting them on an SGLT2 inhibitor.
The acute coronary syndrome, it's the dose that's important, but otherwise it's the LDL target, not the dose that is really matters. Is it not?
Rakesh, you're not visible.
Yeah, so basically you're right. So in the acute coronary syndrome patient, the question is it the anti-inflammatory effect? Is it the LDL drop? Or is it some other pleiotropic effect? And we don't really know which one it is because we can't compare an agent that just purely lowers LDL. So we don't have something that purely lowers LDL. Perhaps a study that says PCSK9 versus a statin might be one way to do it, whereas the PCSK9 really doesn't have an anti-inflammatory effect. But for sure, what we do now is we give them everything as much as we can in terms of lowering that LDL in the acute coronary syndrome. But we know that after that, that's when all of the events begin to occur. So you save the person, and all the other vessels are the ones that are getting that patient into trouble. And in that situation, statin plus something else, so PCSK9 inhibitor, IPE, whatever you want to choose, would be helpful. So that's why I think the statin dosing is still so important, that we get the best one at the base of this pyramid that we're going to be building for our patients.
Thank you, Dr. Lin. I had to interrupt because of lack of time. It's an extremely interesting talk. Maybe now go to Dr. Clyde Yancey.
Sir, there's a small change that we would want to do Dr. Neil Poulter first.
Okay.
With Dr. Yancey's permission.
Yeah. Okay.
Yes.
Yeah.
Thank you, sir. Thank you for
thank you.
that.
Thank you for the very generous gesture.
Right.
Dr. Poulter, please. May we have your talk, Dr.
Can we
Neil
start
Poulter,
your
please?
presentation? Share your presentation, please.
Yeah.
Good evening, everybody. My name is Neil Poulter, and that's the title I'll be talking to over the next 15 minutes or so. This is a nominal conflict of interest. I don't believe I have one, but I'm duty-bound to show you this slide anyway. The first question is, why would we consider changing the time of when we give our tablets? Why would it matter? Well, this slide says it. Raised blood pressure is the biggest contributor to the global burden of disease and to global mortality, leading to 9.4 million deaths. That was as of 5 years ago. Within 2 years, it had risen to 10.4 million deaths. So it's clearly very important that we do sort out and optimize our treatment of raised blood pressure. So how are we doing around the world? Well, this slide shows not very well in terms of control. 4 regions of the world: top left, Latin America and Caribbean; top right, Europe and Eastern Mediterranean; bottom right, Sub-Saharan Africa; and bottom left, Southeast Asia and the Western Pacific. And there are 5 columns for each of those regions. You start in the first column with 100% of hypertensives, and you work across how many have ever had their blood pressure measured, how many have been diagnosed, how many have been treated, and finally, the last column is what percentage of hypertensives in these regions are controlled. And you can see that wherever you are in the world, that percentage is well below 20%, well below 1 in 5 hypertensives are getting their blood pressures treated to 140/90. So we're doing it very badly. Now, I've put here a list of 7 reasons why we don't control blood pressure very well, and highlighted 2 of them which relate, I think, to this issue about when to give the tablets. Have we got ineffective drugs? Would the timing of the drugs affect their efficacy? And secondly, would the timing of the drugs affect compliance? Well, what we do know from the recent ISH guidelines of this year, that the ideal characteristics of a drug include using once daily regimen, which gives 24-hour blood pressure control. And one has to wonder, if you do give drugs that give full 24-hour control, is it likely to matter when you give the tablets? Why do some people think it does matter? Well, here's some prospective observational data on the left-hand side for systolic, the right-hand side for diastolic, which shows whether nighttime, 24-hour blood pressure, daytime or clinic blood pressures, how they predict cardiovascular death on the vertical axis. And you can see for any one level of blood pressure, systolic here, nighttime is a stronger predictor than 24-hour, than for daytime, than for clinic, for any one given level of systolic. The same pattern is true for diastolic. So giving this preeminence to the importance of nighttime pressures. We also know about dipping and non-dipping. The normal diurnal pattern is for blood pressure to dip at night, and the text here, non-dipping, conveys a worse prognosis, whatever your 24-hour blood pressure control is. And the absence of the normal dipping at night and how much you dip at night predicts mortality in hypertensive patients. On the right-hand side here, you can see here survival rates. Here you are for people who dip in the normal ways and those who don't. Survival is consistently worse if you don't dip. More contemporary data, observational data like this, comes from a Japanese study of ambulatory blood pressure monitoring, relatively small, but nevertheless they were able to conclude quite clearly that nighttime blood pressure levels and patterns of what they call a riser pattern, i.e. blood pressures that rise at night, were independently associated with the total cardiovascular event rate, and particularly for heart failure. So there's observational data which links nighttime pressures more strongly with cardiovascular events than any other type of blood pressure times of day or clinical blood pressures. So what about the evidence for whether when you take your tablet matters? Well, you'll see here it's limited. There's some observational data from Spain and Poland. Here are two studies which suggest that the taking of tablets at night might be more protective. Then you've got 4 trials I've shown here, which people may well know, in which the drugs that were given at night. HOPE, FACIT, CISCHINA, and CISTURE. HOPE, everybody knows, of course, ramipril was given at night in that trial and gave really big cardiovascular benefits. And people were surprised because the blood pressure lowering during the day was only about 3/2. However, the blood pressure lowering at night was very good because it's a relatively short-acting agent. The drug was given at night, and so it was thought, well, maybe that's why ramipril did so well in that trial. But have we got comparative day versus night randomized trials on cardiovascular events? Well, I've said no, we don't. Now, you may say, but what about the HYGEA trial? And I'll come back to that. What we do have is the HARMONY trial, which compared in a randomized clinical trial, giving the tablets at day or night. It was a crossover trial, day to night or night to day, but the primary endpoint was only on ambulatory systolic blood pressure results. And this slide shows those results. When you took this as the mean 24-hour systolic blood pressure on people who are on 1 or more tablets for their hypertension. And you see here where you gave your tablets made absolutely no difference on the 24-hour blood pressure, nor did on the 24-hour diastolic blood pressure. So at least in terms of the blood pressures recorded over 24 hours, there was no advantage in taking your tablets at day or night. That could reflect that in the places where this was done, it was London and Greece, maybe people were using 24-hour blood pressure drugs that lowered the blood pressure for 24 hours. But whatever, there was no advantage in when you took the tablets. The conclusion was then that in treated hypertensive patients with stable levels, the timing of antihypertensive drug administration, whether in the morning or the evening, did not affect mean 24-hour ambulatory levels. And also not shown, it didn't affect the quality of life. So along came the HYGEA trial. Here you see the HYGEA trial, and this is the thing that's caused such a big stir around the world. Should we now be giving our tablets at bedtime, as this trial, so-called trial, would recommend? Well, I have to tell you, I don't believe the results, and this is one of the reasons I don't believe it. Here are the endpoints. All these are big, hard endpoints at the top. Total events, total cardiovascular outcomes, strokes, coronary events, cardiac events, and minor events, all showing in excess of a 40-odd% reduction in cardiovascular events. These are broken down in the bottom half of the slide here to all the different types of cardiovascular events, and they're all significantly different, all between 60 and 40% benefit associated with giving the tablets at night. Not time to show you, but if you look at the subgroups in this trial, every single subgroup had these huge benefits in cardiovascular outcomes. over 30 or 40 years of being involved with cardiovascular trials, I have never, ever, ever seen this size of reduction in cardiovascular events associated with an intervention, whether it's aspirin, streptokinase, statins, HM, etc. Just never seen this sort of benefit. So I personally came to the conclusion that these data were not correct and worried about whether it was a trial or not. That was supported by this article in the Journal of Hypertension this year, 4 or 5 heavyweight names in the world of hypertension, whose title was Disregard the Reported Data from the HYGEA Project, and that blood pressure medication should not be routinely dosed at bedtime. Why do they say that? Well, it looks as though this was not a proper randomized trial. Rather, it looks like some multiple observation studies were put together and collated and called the HYGEA Project rather than a trial. Some examples of the concern are there was no loss to follow-up. 800 out of 19,000 dropped out. Now, anyone who's been involved with trials know that loss to follow-up is usually much bigger and a lot more drop out. There was apparently no adjudication or record of audit of the events that were reported. And as I've mentioned, the results are totally implausible. So their punchline of this editorial was the reported data from the HYGEA Project must be disregarded. Blood pressure medication should not be routinely dosed at bedtime necessarily. I tell my patients to take their tablets at the time that suits them best. I give drugs that act for 24 hours, so to my mind it doesn't matter. So whatever is going to make it easier for them is when I advise them to take their blood pressure tablets. So in summary, what we have got is we know that nocturnal blood pressure is a better predictor of cardiovascular events than daytime pressure or 24-hour blood pressures or clinic pressures. Some observational data have suggested that giving the tablets at night may be superior in terms of cardiovascular protection, but then along came the HYGEA trial, which gave really surprising results, and these are being investigated. Now,
excuse me, we have lost Dr. Polter's audio.
No, we can hear him well. We can hear him well.
It is coming, sir. It is coming, sir. Ask Arun to check there, sir.
It's fine. Carry on, Dr. Polter, please. Sorry.
Thank you. What we do have is the time trial in progress. That's got 23,000 people properly randomized. And as the independent chair of this trial, I asked the data safety monitoring.
Unfortunately, we have lost Dr. Polter's audio.
There is something wrong with
No, sir. We are hearing, sir. We are hearing, sir. Here, all of us are hearing, sir.
There's something wrong at your end, Dr. Venu. We can hear him.
We are sorry. Carry on, Dr. Polter, please.
Okay, I'm sorry if you've missed, or I'll try and carry on. What I'm saying is that what we do have is the thing called the time trial. This is a properly conducted trial of over 23,000 people randomized to get their tablets at daytime and nighttime, followed up.
Call them.
Now, what we did was to, in light of the HYGEA trial, was ask the time trial data safety monitoring committee to check the time trial data to see if we should stop the trial for ethical reasons in light of the HYGEA trial. And the data safety monitoring committee advised us there was no reason to stop the time trial and absolutely no evidence to support a reason to do so. So, in the meantime, we've got no good data to recommend nocturnal dosing. So, question, should we lower nighttime blood pressure with bedtime dosing of antihypertensive medications? Well, on the basis of current evidence, the answer is a very clear no, we should not. I have to say that I recommend patients to take amlodipine or any of the dihydropyridines. If they're getting ankle edema, take them at night, it might help. But other than that, it should be about adherence. Whenever it's best to make sure the patients take their tablets, do it then. But in the meantime, let's see what the time trial tells us. Thank you for your attention.
Thank you, Dr. Polter, for this lovely thoughts on the high gear trial. High gear trial truly has been hyped enormously, and it's really nice to hear your thoughts on the methodology of conducting the trial. And coming from a wizard like you who spent a lifetime on trials in hypertension, it just puts it into its right perspective. And possibly the evidence base is yet lacking in terms of, even I actually was thinking that most of the drugs are more than 24 hours duration of action. We ought to be a little bit conscious of the duration of action of an agent when we are choosing antihypertensive drugs. Like losartan, if you are using, it's better to use it twice a day. But if you are using telmisartan or amlodipine, which truly have actually a really long duration of action, it's not going to really matter today. And also the drug compliance issue with the frequency of dosing. And today we live in an era when we talk of the single pill combination, and we want to reduce the pill burden of our patients. So the data that interpretation that you have given of the high trial is truly interesting. But I just wanted to ask you, we did the India ambulatory blood pressure trial, which was a very large study, and we found that about 11% of patients had only nighttime hypertension. Uh, so, what are your thoughts on this morning surge, nighttime hypertension? You have touched on beautifully, you've shown us that it correlates with end organs. How do we hit at it in a better way?
Well, thank you very much indeed, Dr. Wanda. I think that when you do a large survey, an ambulatory survey of the general population, you will get a percentage who do only have nighttime hypertension, which of course, unless you do it as a sample, you wouldn't pick up in your clinics, that no doctors would know about it. That it's slightly confounded on some of these because they're nighttime workers. Obviously, I don't know the 11% whether you got their occupation, but it may be that half of them were working at night and sleeping during the day. That may explain some of it. But there's no doubt nighttime hypertension in isolation is a problem unless it's dissociated with sleep. If you're getting it at night, it is associated with more mortality. It's associated with more death. And cardiovascular hypertension mediated target disease, organ damage. You can see that there. The difficulty you raise is, though, that we're not going to pick that unless we do ABPMs on everybody. And that's one of our problems. It was interesting, there seemed to be some ethnic differences on the prevalence of nocturnal hypertension. I know the African Caribbean society, population tend to have higher nighttime blood pressures relative to their daytime. But more than that, we don't know. And whether we should treat it, I suppose if you find it, the best bet is that we maybe should treat it.
For them, an ACE inhibitor may be a better choice, nocturnal hypertension.
I wouldn't have thought particularly the ACE inhibitor. If you've got really good lowish blood pressure during the day, but then you discovered this rising pattern at night, which the Japanese detected too, my treatment would be probably for a shorter acting agent. And that's one of the few times you might say, okay, let's treat the agent, a short acting one that isn't going to affect the daytime because they're already pretty low. In general, I use ACE inhibitors first line for younger patients, but I'm tending to use drugs in combinations. You know, the European and the ISH guidelines now saying 2 drugs. So if I were to use agents, it's my usual combination is an ACE inhibitor with a dihydropyridine calcium channel blocker. And you'd be able to do it very nice low dose there if it was just nighttime you were treating.
Well, thank you, Dr. Polter, for it's always a pleasure to actually listen to you, how beautifully you look at data and analyze, and we would be looking forward to the data from time study trial as to what it tells us and whether it really makes a difference as to the timing of high gear trial is being discussed extensively in India also, and your talk does put it in its right perspective. Thank you very much for your discourse.
Thank you very much. My very best wishes to everybody, and thank you for chairing, Dr. Wanda. Thank you. Goodbye.
So we now move on to the next talk by Dr. Clyde Yancey, and it's a pleasure actually to request Dr. Yancey to give his talk on heart failure care beyond 2020, impact of new data. Is that all right? Yeah, Dr. Clyde Yancey, please.
Great, thank you. Thank you for this invitation. Let me share my screen and be certain that we can all see the same thing.
Visible.
Please confirm that you're able to see my first graphic.
Yeah, very much on.
We can.
It says heart failure care beyond 2020, correct?
Yes.
Great, thank you. I'd like to thank the organizers for the opportunity to visit with you today and to be a part of this spectacular program. I've been intrigued with the presentations I've heard so far. Dr. Peter Lin actually did a beautiful job of creating a segue for much of the content that I'm going to share with you, since I will discuss at length the SGLT2 inhibitor class in the treatment of heart failure. But I was also fascinated with Dr. Poulter's conversation, because like Dr. Poulter, I've had a long-standing interest in hypertension. I'll briefly mention that shortly. And I think the HYGEA trial and how that redirected us and the necessity to go back and do the time trial really are important data that will have worldwide implications. But let me proceed with what I hope will be helpful. I know this meeting has been going on for several days, and I applaud you for the organization that you put together. Your virtual format looks outstanding. You've had quite a bit of content that has come forward already in heart failure, and I hope that my presentation will bring some of that information together in a way that will help us all understand what happens as we go forward. Let me start then with a very straightforward approach. What is heart failure? The definitions were nicely articulated in the American College of Cardiology, American Heart Association Clinical Practice Guidelines published in 2013, which I had the privilege to chair. We went ahead and identified the different phenotypes, reduced ejection fraction, preserved ejection fraction, but we had the presence of mind to also articulate that there's another category, the ejection fractions between 40 and 50. And we opined, not based on much data, the one group basically was borderline, but the other group reflected a very interesting group that had previously had very poor ejection fraction, but had improved to something greater than 40. We call that HFpEF improved. Most of us today would call that heart failure with mid-range ejection fraction. And importantly, there is a statement that will soon be available, which is going to be a new universal definition and classification of heart failure. It is a coalescence of multiple international groups, including the ESC and the HFSA, to really help everyone have this same vernacular when we're talking about heart failure. So stay tuned for this. This will be very helpful. But let's go ahead and explore the data. Again, the context that I'm sharing with you is how do we take the newest information and articulate that in a way that we will be both preventing and treating heart failure in 2020 and beyond. Let's start briefly with prevention. There are new data, there are new targets, and there's new statement about women and the prevention of heart failure. This is the classic template that we use to understand heart failure. It is separated into stages. The stages are progressive. The stages are inviolate when you progress from one stage to the next. You can't go backwards. The first part of these thoughts then really reflect our anxieties about preventing this disease, because no matter how good treatment is, it's much better to not have this disease at the outset. If we're talking about prevention, then we go immediately to the conversation that we just enjoyed with Dr. Poulter. What's the best treatment for hypertension? That best therapy today is guided by the SPRINT data published 5 years ago, but uniquely executed in a group of patients at higher cardiovascular risk. So this is not all hypertensives, but hypertensives at higher cardiovascular risk. In treating these patients intensively to lowering blood pressure to less than 120/80 resulted in substantial benefits that were in part driven by the prevention of heart failure. Yes, there was an overall impressive mortality benefit, but also a 39% reduction in the likelihood of developing heart failure of sufficient severity to warrant hospitalization. These are important data, and I would argue the most substantial data yet that we can prevent the onset of heart failure by treating hypertension appropriately in those at higher risk. In addition to focusing on the hypertensive patient, what about the diabetic patient? We've been caught up with great enthusiasm using the SGLT2 class as therapy for those with symptomatic disease. But the first and most important signals came out in the prevention of heart failure. These are the original EMPERAG data, just 3 years old now, that demonstrated that in a trial designed to just simply show the absence of harm from a glucose-lowering agent, remarkably, there was this benefit seen with a dramatic reduction in new onset hospitalizations for heart failure using empagliflozin. What has since evolved has been the evolution of positive data in all of the drug classes that have been evaluated within this SGLT2 inhibitor space. The EMPERAG program, the canagliflozin program, the dapagliflozin program, all of these data points demonstrated that in patients at higher cardiovascular disease risk, there's a consistent signal that documents nicely the prevention of heart failure events. So let's not overlook these predicate data now to say that we can prevent heart failure both by targeting the treatment of hypertension in those at high risk and the treatment of diabetes using the SGLT2 inhibitors in those at higher risk. But we can go beyond that. Now we have a very impressive score. If you're not using this, let me be very clear with you. It's called the H2FPEF score. You can see the clinical variables and you can see how easy the scale is to apply. The heavier patient, this older, this hypertensive, when you add up the point score, you can see how easily you can identify the probability of HFpEF in the patient with symptoms. This is important because it gives you the opportunity to hone in quickly on the comorbidities and use that as a means to change the natural history of heart failure with preserved ejection fraction. And then what about women? We must recall that women are uniquely at risk for heart failure, in part because of the exposure to chemotherapeutics due to breast cancer, in part because of obesity and inactivity leading to heart failure with preserved ejection fraction. These are important targets that we cannot overlook. But now let's move on from prevention, understanding those new data points that give us a different context about how we can prevent the disease. Let's think about how we treat the disease. What is the current paradigm? What is that standard of care? This is it. This is from an update in our guidelines that we published in 2016. We published another one in 2017. And now our committee is working on a brand new set of heart failure guidelines we published in 2021. I'm no longer chair, but I'm still an active member of the guideline writing committee. This is a multi-step process, a 5-step process, looking at the patient that has symptoms consistent with heart failure, taking a picture, make an assessment of the ejection fraction, starting evidence-based ACE or ARB, preferably the ACE inhibitor, with an evidence-based beta blocker, diuretic is needed for decongestion, and then going through 6 interrogatories. That's step 2. Each of the answers here prompts another highly regarded therapy for heart failure, and none of the answers are mutually exclusive. Working through this algorithm, one can identify a semi-personalized approach in the treatment of heart failure for a given patient. We've made this easy. In 2017, we released an app from the American College of Cardiology that, again, we helped to develop. This is called the Treat HF app. You can find it in the Google Play if you're using a Google device, or in the App Store if you're using an Apple device. But it has been evaluated, deployed, promulgated as a strategy to help optimize therapy for heart failure And this too is being updated as new data points have come about. We believe that we'll have another version of this in 2021. So I've taken you through prevention with the top line new issues, and I've challenged you with what it is that we're doing in 2020 based on what we already know. But I'm sharing with you that this multi-drug regimen may not work as well as we think. And the landmark data, CHAMP-HF, which is an observational analysis, evaluating clinical practices in the United States that knew they were participating in quality improvement program, assessing the adequacy in the treatment of heart failure, what we discovered was sobering. Less than 25% of patients were on one of the major classes, either a RAS inhibitor, an evidence beta blocker, or mineralocorticoid antagonist, and only 1% were on the target doses in each of these classes. When we even looked at 12 months, that was baseline, we saw that there had been fundamentally no change, no new initiation if the patient wasn't on therapy, and no titration. This is a huge issue, but it points out how challenging it is to provide these multi-drug regimens to ambulatory patients with heart failure. What we're doing here at my institution in Chicago at Northwestern University is actually developing a polypill for heart failure. We have the funding, and we actually intend to launch our first study in India, looking at a 3-component compound, an ARB, a generic beta blocker indicated for heart failure, diuretic, with the hope that we can demonstrate that by bringing everything together as a convenient polypill, we can overcome some of the clinical inertia that is limiting our ability to see the optimal benefit. But let's go to beyond what we already know and to where we are going now. Are there new relevant data? And I've already given you a hint that this is going to be a discussion about new concepts and new applications. The new concept first is HFpEF. I need not take you through the complexity of HFpEF, the heterogeneity of this disease state, the multiple organ systems that are involved, but I do need to remind you that an important clinical trial, Paragon-HF, was executed using the ARNI compound, the combination of sacubitril and valsartan for patients with symptomatic preserved ejection fraction heart failure. This is the study design. Patients were deemed eligible after tolerating either full doses of valsartan or full doses of the combination therapy. Then they were randomized to either the combination therapy or the full dose of valsartan. And the primary endpoint was one appropriate for many of the clinical trials that we've executed, including a composite of total hospitalizations and cardiovascular death with important secondary endpoints as you see here. What were the data? A near miss, just barely missed statistical significance in favor of the ARNI compound in patients with HFpEF. This is different from Paradigm-HF, which was in HFrEF. If we then break the composite endpoint into its component issues, we see the signal a little bit better, but still not statistically significant for hospitalizations. But it is here where we become very intrigued, because in women, it looks as if the point estimate was very suggestive. And when the median ejection fraction was evaluated in this trial, the median being 57%, at or below 57%, a very compelling point estimate. So much so that these data are under evaluation by the United States Food and Drug Administration, potentially as a new indication for the ARNI compound for patients with mid-range ejection fraction heart failure, maybe preferentially for women. But what about the SGLT2 inhibitors? Will this new drug class make a difference? And I think the answer is yes. These data are just a year old, but they're landmark data from DAPA-HF. You've heard from Dr. John McMurray in this Cardiology Society of India meeting, but I'll just highlight that across the board, the primary outcome and all the composites of the primary outcome, including total mortality, were uniquely and remarkably positive. But what was really the most impressive point here was that whereas the previous prevention data were obtained from those with diabetes, these data showed there was no necessity to require diabetes in order to identify this treatment benefit. In the absence or presence of diabetes, the point estimate was quite substantial. This has become an inflection point in the care of patients with heart failure. The benefit is seen in those with without diabetes. In the case of dapagliflozin, it's once-a-day therapy, a single dose, no need for titration. The safety profile was very good. No hypoglycemia, no diabetic ketoacidosis, even negligible incidence of amputations previously seen in earlier trials. And the number needed to treat was a very impressive 21. And we had data provided in patients over the age of 75. Hardly ever do we see this kind of robustness in a data set, but it was just with DAPA-HF. But this summer in July, there was a press release that empagliflozin met its primary endpoint. And 1 month later, in the New England Journal of Medicine, we saw these data published and evaluated and presented at the ESC meeting. These data, again, showed a primary outcome and the totality of hospitalizations being in favor of an important treatment effect. If we look at the preservation of renal function, decidedly in favor of empagliflozin, so much so that this cardiorenal interface has become very important. We recognize that there are mechanisms that drive renal disease and cardiovascular disease, and they are quite similar. So in the DAPA-CKD study that was also presented at the ESC just several months ago, we saw this compelling information where a primary composite outcome was remarkably positive, so much so that the trial was stopped early, and this outcome included death from renal or cardiovascular causes of progressing to the necessity for dialysis. Very important data. Number needed to treat of only 19. Again, a very, very important observation. And this curve is almost superimposable on the empagliflozin data. So it really demonstrates a consistency of the benefit of these drugs to preserve renal function. Most recently, we've seen in the SCORED study, published just weeks ago in the New England Journal of Medicine, in patients with diabetes, chronic kidney disease with or without albuminuria. Again, a prevention of cardiovascular events that are seen here. And again, seen here, the first occurrence of death from cardiovascular causes, non-fatal MI or non-fatal stroke. And then in the SOLOIST worsening heart failure trial, remarkably, we saw that in patients with diabetes who received this particular SGLT drug, there was evidence of a preservation of health, a reduction of cardiovascular events. What's different about this drug is that it targets both the first and second receptors, or receptor 1 and 2. So stay tuned for more information there. So if we try to put the full portfolio together, the RNA compound and the SGLT2 inhibitors, it is remarkable to know that despite this evidence base, the SGLT2 inhibitor, at least in the United States, is not yet currently supported by the heart failure guidelines. We expect that to change in 2021, but I'm not at liberty to say how. But there are multiple positive trials. For HFpEF, we're waiting EMPEROR reduce for the SGLT2 inhibitor. We're waiting for the FDA to evaluate the impressive data I shared with you from the Paragon-HF, admittedly secondary outcomes. And then for the mid-range ejection fraction, again, we're waiting for the FDA to look at those mid-range numbers between 45 and 57 and tell us if there's a benefit there. But what about even going further beyond? This evolution of discovery in heart failure has continued. There have been 3 important trials looking at Vericiguat, omecamtiv mecarbil, and iron replacement. Vericiguat is a soluble guanylyl cyclase activator which restores the homeostasis of cyclic GMP, and cyclic GMP is important in cardiovascular vasomotor regulation, the heart, the blood vessels, and the kidney. The data from the Victoria trial, modestly positive, but positive in a group of patients that had already developed evidence of worsening heart failure. This may be a benefit that we'll see going forward. What about omecamtiv mecarbil? A very interesting compound, the first in a class of new compounds known as myotropes. It improves cardiac performance without increasing myocardial O2 consumption. Look at panel B and panel C. You can see an increase in the efficiency of actin-myosin interdigitation. In the trial brought forward by the GALACTIC-HF investigators, it too was a positive study, this time mostly driven by those patients with very low ejection fraction and advancing symptoms. This too may become a part of our treatment strategy going beyond 2020 and into 2021 and beyond. And then this brilliant trial done by our colleagues in Europe, looking at the replacement of iron in those with iron deficiency, not requiring the presence of anemia. And this AFFIRM AHF study, again, a primary outcome looking specifically at hospitalization and morbidity, suggesting that there was a benefit with iron repletion in patients that were iron deficient. So here's my summary that details what I think will be different going from 2020 to 21 and beyond. First, there is an important necessity to recalibrate and focus on prevention of heart failure. Second, we do have in hand effective guideline-directed medical therapy. We can alter the history of heart failure with reduced ejection fraction, but we have to overcome this implementation problem. HFpEF remains a challenge. The H2 FPEF score is helpful. Evaluating the comorbidities is necessary. We have multiple signals, nothing definitive, whether it's the ARBs, the aldosterone antagonists, and now the RNA compound. All of these are intriguing. We understand the SGLT2 class may be the breakthrough therapy. Evidence that I've shared with you for prevention, evidence I've shared with you for the treatment of HFrEF, evidence I've shared with you for the intersectionality between the heart and the kidney. We're waiting for HFpEF. We don't know about mid-range ejection fraction, but this could be a breakthrough drug class. We now understand that other therapies are coming. Versquat, omecamtiv, iron replacement. All of these compounds will continue to change the paradigm. What I've tried to share with you is that we are excited. From 2020 going to 2021, the likelihood exists that we will be able to treat heart failure better than ever before. Now we have to overcome the challenges of implementation, costs, multi-drug regimens, and keep evaluating the science, understanding how we can make this more personal, more focused, and have an even greater understanding of heart failure, particularly those phenotypes that we don't yet have fully addressed. Thank you for the invitation. Delighted to be a part of today's program.
Thank you, Dr. Yancey Clyde, for this beautiful, it's really wonderful how so much you can cover in such a short time, taking from prevention to therapeutics and emphasizing how the knowledge that we acquire gets translated in clinical practices. In fact, we did the Asian heart failure trial in Asian population, and we fared equally bad in terms of translating the data in providing our patients with this triple therapy. And we all need to work across the globe in terms of how we can best reduce this inertia and provide adequate dosages to our patients. I just have two questions from you from your beautiful talk. Would it be time, by the time the FDA actually looks at the Paragon HF, should I interpret it that women and those with the mid-range ejection fraction would be the subset of patients who would be candidates for the ARNIs as the data that you have projected? Should it be translated in that terms?
So Dr. Wonder, you and I are the same mindset. That's likely the way that the FDA is going to interpret it. But as mature investigators and clinician scientists, we understand that there's a deeper question that the Paragon HF data bring forward. Do we know what's a normal ejection fraction? Do we know where the cut point is for reduced DF and preserved DF? Might it not be a continuum? Might it not be that at the molecular level, there'll be much better predictors of who will respond to RAS inhibition, beta blockers, and MRA versus the RNA compound? I think that we have conveniently allowed this surrogate marker of the phenotypes of heart failure to predominate in our scientific thought. And we need to challenge that premise and go back to say, what constitutes the correct indication for the RNA, the correct indication for the ACE? Right now, it's a convenience sample, just based on a crude measurement that comes from multiple echo labs across the globe, and it's not the same number in the same lab. It could be different for women. We still wrestle with that, and that may be why we see that signal. So I agree with you. I think there's something in the Paragon HF data, and I think the FDA will probably make a decision in favor of treatment, but I don't think those of us that believe the importance of understanding pathophysiology will accept it as sufficient.
And how do I take your interpretation of the SGLT data, which is equally exciting? Should it be that the cardiorenal syndrome patients with chronic heart failure with CKD element, those are an absolute candidates for for DEPA, because we have data from DEPA-HF and the DEPA-CKD now. So would that be a subset of patients? Because cost is a factor in this country. We keep looking at which are the real patients who should not be denied an expensive therapy. So what would be your interpretation in terms of these renal issues, which we see so often in our patients with heart failure?
So Dr. Wonder, one of the things that really informs my research and my writing is that I'm an active practitioner. I'm a clinician. I see patients multiple days a week, and I take care of patients on a regular basis. In the treatment of heart failure, I need blood pressure and I need kidneys. If I've got both of those working for me, I believe I can make anyone feel better. But if I don't have blood pressure, and if the kidney function is not intact, there's very little that me or any other heart failure physician can do. I use that intro to say that the preservation of renal function with an agent that also improves cardiovascular outcomes in heart failure, I think is a bigger breakthrough than any of the other therapies we've had before, meaning that we, leaders in global cardiovascular medicine, need to find a way to overcome the cost inertia, because the price we pay when we can't give patients with a terribly symptomatic disease that shortens their life expectancy therapies that will preserve their function is just unacceptable. We've got this portfolio now, Dr. Wander, of about 9 drugs with an indication for heart failure. Does everyone need all 9 drugs? I wonder if we can truncate that, as you outlined, the patient with concomitant renal disease and heart failure. Let that patient start with the SGLT2 inhibitor. The patient with ischemic heart disease, maybe that patient starts with a beta blocker. I mean, we need to be a little bit more intelligent about how we deploy these agents. But I won't back away from the notion that the ability to preserve renal function in the treatment of patients with heart failure is a brand new day for us. And that information excites me maybe more than anything else.
Dr. Rakesh, I'm sure has some questions.
Most of the time, like we assume that the patient can't afford, or cost is the main reason. So that shouldn't probably make us not to prescribe those drugs. You should always probably say this is expensive, but there is definite mortality benefit. So, I mean, in my experience, most of these patients do accept it and they do take the medicine.
Well, it's a great point you make, Dr. Gopal. I see that Dr. Gersh is on the screen, and he and I for years have had conversations about how do patients that have limited resources navigate this maze of medical therapies, stents, TAVRs, expensive drugs. There's recent data out of this country demonstrating that 50% of our patients experience some element of financial toxicity, where they're making difficult choices about housing, about nutrition, about their medicines. I bring that up only to say that we have to find a way to change the model, whether it's something that's evolving out of healthcare dynamics or what we're trying to do. If we're successful with our polypill project, Dr. Wonder, imagine what happens if we can show that a polypill with inexpensive generic drugs brought together, we'll be testing it in India, is positive. I'm confident that the manufacturers will come to us and say, will you put this SGLT2 inhibitor in the next version of your polypill? Will you put this ARNI compound in the next version? Because countries will rapidly subscribe to an inexpensive pill. We think ours will be $9 a month. They will rapidly subscribe to a polypill in treatment of heart failure. And I think we will put enough pressure on the manufacturers to come to us and say, will you now add our compound to your polypill? We've already been through the compounding. So we are developing and putting the finishing touches on the component that we plan to use, the components we use. But I think there's another version of this.
If you actually are not using ARNI, then we are not giving that additional benefit in terms of mortality and recurrent hospitalizations. So if a patient is not getting these drugs, there's chances that this patient is going to get hospitalized again, and that will negate the entire money probably you are trying to save for him.
No, I agree with you, Dr. Gopal. That is exactly the argument that we've always used, is that the cost benefits are realized with the preservation of costs expended for the hospitalization. But other than the UK and Canada, there are very few systems that are sufficiently interconnected where cost savings in hospital relate to cost savings in the outpatient setting. In the United States, everything's in a silo. If the hospital saves money, the hospital saves money. The outpatient practices don't. If the outpatient practices save money, the hospital doesn't see that. It's only in integrated networks where these downstream cost savings matter and give you the resource to provide the drugs upstream, unless you have, again, single payer systems where that's accommodated. So we're taking a different approach. We're using basically an economic incentive to say, we will come up with a decidedly less expensive way of treating heart failure. And if we can prove, Dr. Gopal, if we can prove that our polyp pill is non-inferior to a regimen that includes the iron compound, doesn't have to be better, just prove that it's non-inferior, that will put a lot of pressure on manufacturers to come to the table and visit with us.
I'm sure Dr. Gersh has a comment to make on this beautiful discussion that we have had on heart failure.
I have, thank you, and I must apologize for, I think I'm about an hour late. The link just didn't work for me, and we had to develop a new link. So I think I gave my presentation probably an hour or two ago, but I'm happy to answer questions about that. No, I really enjoyed Clyde's presentation, and I think that CHAMP registry really, really tells the story. I mean, the field of heart failure in terms of pharmacotherapy and even non-pharmacotherapy devices is very exciting. I mean, probably more than any other area, we really have seen great advances in the last 2 to 3 years, but we're not giving the drugs according to a guideline-directed therapy. We're just not doing it. And so I think I agree with what you said. The focus now is we have tools and we have to implement them. It's a matter of implementation. I just wanted to ask Dr. Yancey one question. I was a bit disappointed with the Galactic trial. I hoped that omecamtiv mecarbil would be a very large breakthrough. But I guess the one thing it doesn't do is drop blood pressure.
Right.
So what is the role? So it may be, where do you see the drug fitting into our therapeutic armamentarium? Because I think the one advantage is it didn't change heart rate or blood pressure.
So Dr. Gersh, I agree with you. It didn't change heart rate. It didn't change blood pressure. And if you look at a non-pre-specified but important subgroup, 4,000 patients with an ejection fraction less than 28 versus 5,000 with an ejection fraction greater than 28, that's where the signal was quite significant.
Yeah.
And we've needed something in that space where patients have a dropping ejection fraction despite being on evidence-based therapy and are at risk for progressing on to mitral clip, VADs, and transplants. That's a big jump. The idea of having something in that continuum like omecamtiv that would forestall the progression of disease, I think that would be important. You and I both know, however, that the sponsor has backed away from the developer and has returned the patent to the developer. So now we have reasonable data with a signal in an important patient population, but no capital to develop it any further. And I'm not certain what will happen. I'm working with the developer now in initial conversations to see, is there a different place we can go to really develop this important concept of the very low ejection fraction patient with heart failure as a potential therapy. That may require a different kind of trial, but we need to refine those data.
Thank you, Dr. Yancey. One tends to be greedy when such an expert like you is there, and there are so many questions, but I think we must thank you for the lovely discourse and the excellent discussion. We'll make use of Dr. Bernard Gersh's presence here. And can I ask you, Dr. Gersh, that was a lovely talk that you did deliver. So what do I take as a take-home message from your talk? What would be the best timing for us to implant an ICD after an infarction? Certainly not less than 1 month, certainly not later than 3 months in those in whom it's indicated. But within that, what would be the kind of best period, and what subset of patients do you think we should not deny this?
I think about 3 months. Clearly in the first month, you can get a significant improvement in ejection fraction. But let me just take a step back, and that is, if the myocardial infarction was complicated by recurrent ventricular arrhythmias, that's a different group of patients. This is really secondary prevention. So if someone came presented with an out-of-hospital cardiac arrest, myocardial infarction, revascularized, and during the hospitalization, they were having recurrent ventricular arrhythmias, I'd put the ICD in before discharge. If it's purely a question of ejection fraction, well, a lot can happen to the ejection fraction between discharge and 3 months. So I would say probably the optimal time is 3 months. And unfortunately, the vest, which is a rather nice idea, hasn't worked out very well in practice. People don't like the vest, they don't comply with the vest. But in someone that I am worried about, that we have to wait the 3 months, but I'm concerned, I'd at least encourage them to use the vest. The one aspect of that talk, of the topic that I find very interesting, is the genetic study, particularly from Paris. And that is, if your parent or both parents died a sudden cardiac death, your risk of dying a sudden cardiac death is substantially increased. If your parents died of a myocardial infarction, then the likelihood is that you will die of a myocardial infarction, not a cardiac arrest. But I think it may be the same pathology, namely plaque rupture and ischemia. And some people are electrically vulnerable to ischemia, so-called repolarization reserve. And so the concern I have in someone who's presented with an out-of-hospital or in-hospital cardiac arrest is when they next have an ischemic event in 2 to 3 or 4 years' time, is the same thing going to happen again? And that's something that I think at a much more basic level is an incredibly important topic, and that is, can we identify the electrically vulnerable patient? You know, some people have plaque rupture and they go on and have a myocardial infarction, and others fibrillate. Why? We don't know. And that's, I think, really, in a way, the message. The other point I'd make about not I think, delaying 3 months if you can, is the data I did show. There are 2 studies now that suggest that 2 studies and 2 trials that really did not show a benefit of the ICD in the first 30 days. And that's because I think people are dying of rupture, recurrent ischemia, recurrent infarction. And so the arrhythmia they get is just a surrogate of that. So it's really, I think 3 months would be probably the right time.
And looking at the second part, just a short question, just looking at the subset that you were discussing, patients out of hospital arrest, they come to you, you find revascularizable lesions, multiple lesions. You did clarify on a single lesion. And then you revascularize such a patient, maybe a CABG. What percentage, you did show us in your own center about 40% of them, but how do you interpret that data now? Since you were kind of indicating that many of them would require an ICD. So what's the current practice in that subset?
Yeah, it's a very difficult area, and basically the data are pretty old. But if you put it all together, I think we can say the following: that people who presented with an out-of-hospital cardiac arrest, who were revascularized with multivessel disease, that it's partially protected, but not totally protected. They still, and our own Mayo data, I think we showed if the ejection fraction was sort of, even if it was above 35 to 40%, and they were revascularized, there was still a significant incidence of late device discharges. So let me turn your question around just a little bit. Is there anybody that I would not put an ICD in? Well, if you had a patient who had an out-of-hospital arrest, single vessel disease, plaque rupture, thrombus, revascularized, good ejection fraction, I think we've probably taken care of the problem. But with multi-vessel disease, even revascularized, there's not a great deal of evidence, but all the evidence that we have says they are still at risk. And therefore, we revascularize everybody, but most people will get an ICD.
Dr. Gersh, you are talking about a genetic predisposition to sudden cardiac death in these patients. How important is that?
Don't know. I'm intrigued by the data. It's a good question. I'm intrigued by the data from this very good study, prospective study in Paris and France, suggesting that there is a strong genetic component. From a practical standpoint, this is incredibly interesting, I think, from a basic science and genetic standpoint. But from a practical standpoint, all we can say is that people who present with an out-of-hospital or even in-hospital cardiac arrest and a myocardial infarction and have extensive disease, even though they are revascularized, they are still at risk of recurrent events. Recurrent ischemic events, and they've already declared themselves and shown that when they get ischemic, they fibrillate. So I think it's a genetic tendency or trait, but all I can say is they're at risk of recurrent events, and ICDs are affected.
May I ask a question to both of you? That is, we have been discussing about ejection fraction. Now there is a lot of discussion to other parameters of assessing LV function, like left ventricular end systolic volume. Would you give a comment on that? Especially in heart failure. There are a lot of now reports coming in.
Let me change it and throw a question to Dr. Yancey. So if you look at Paragon, I mean, my interpretation at Paragon, I'm just being a bit controversial here, is in that group with an ejection fraction of sort of 40 to 55%, I wouldn't even, maybe they're not HFpEF, it's just mild HFrEF.
Yep. So that's not being controversial, Bernard. I think you're right. I think that we have really truncated our conversation. We forced a fit. We recruited convenience samples when we did the HFrEF trials. I did many of them and had a top tier cutoff of 40%. That was empiric. It wasn't based on science.
I've heard you say that before.
Yeah, and so what we're seeing in the 40 to 55 range are people that have that same substrate that just isn't as impaired as before. But I really like Dr. Kochi's question because you are thinking in the same direction that we're thinking. First, many of us, if the technology is available, are beginning to default to the cardiac MR as an initial assessment of ventricular integrity because we not only get ejection fraction volume, but importantly, we get markers of fibrosis and we get markers of inflammation. And so we can walk away from one study and have a sense of, is there an infiltrating lesion? Is cardiac amyloidosis a concern? Sarcoidosis. Is there a concern for an arrhythmia risk? You just heard a beautiful description by Dr. Gersh of the necessity to think critically about who gets the device and who doesn't. There are reasonable data, not acquired prospectively in a trial, that if there's evidence of delayed enhancement on cardiac MRI, those patients may actually suffer sudden death events at a higher rate. So where we're going in the field is the following. With echo, we're looking much more carefully at global longitudinal strain, another parameter that is less load dependent than ejection fraction. And if cardiac MR is available, we're looking at a whole portfolio of T1, T2 relaxation times, extracellular volumes, evidence of fibrosis. It really, again, is exciting. But what's interesting is to go back to something that's much more readily accessible. More and more, we're beginning to see the use of handheld point of care ultrasound. Literally in your pocket in the emergency department, you take a device out of your pocket. The price now is down to about $1,000. And if you're using it for all comers, it becomes affordable. You can find out right away if someone has poor ventricular function or reasonable ventricular function, and the necessity to discriminate therapy can start on demand without waiting for referral to an echo lab. And with the advent of artificial intelligence and machine learning, we can actually coach using software a novice to get a high quality study. We publish those data out of our center, and we can overread the studies remotely. And so there's a way that we can use the conventional data more intelligently. There's a way that we can take the echo in a more sophisticated way and get better discrimination of ventricular performance. And the cardiac MR is opening up a brand new suite of opportunities for us.
Thank you so much. I think we have one more talk. Dr. Nausheen Akhtar's talk is pending. Can we have the last talk, recorded talk from Dr. Nausheen Akhtar?
We are playing, sir.
Yeah.
Thank you. We'll see you later.
Thank you.
Thank you to the conference organizers
It is really
for,
great listening to both
the
of you.
opportunity to
We
present.
really enjoyed.
Today, my name is Nausheen Akhtar, and I'm an associate professor of medicine at Northwestern's Feinberg School of Medicine. I'm also the director of cardio-oncology. The topic of my presentation is presentation, surveillance, and management of anthracycline cardiotoxicity, and I have no disclosures. We have been using anthracycline-based chemotherapy for several decades. The classic paper was published in 1971 describing 2 cases of 12-year-old patients who developed heart failure following daunorubicin treatment. This was picked up by electrocardiogram. You can see here in figure 1A pre-treatment and then figure 1B post-treatment with daunorubicin. There's a left axis shift. On the heart necroscopy, there is evidence of myofibril shrinkage, atrophy, vascularization, and loss of fibers. There have been notable improvements in the survival rates for most cancer types due to earlier detection, advances in treatment. And for example, the improvement in lymphoma has gone from 34% up to 63% in the most recent time period. The asterisks represent where anthracycline use is common in breast leukemia and lymphoma. We see here that survivorship is increasing. I want to present a case of a 66-year-old woman with a history of stage 2 triple negative breast cancer. She's status post left-sided mastectomy, which is followed by an adjuvant dose-dense ACT, which represents doxorubicin, cyclophosphamide, and paclitaxel. The total dose administered here was 240 milligrams per meter squared of doxorubicin. She is then unfortunately diagnosed with ALK positive anaplastic large cell lymphoma and started treatment with BVCHP and has had 2 cycles of this prior to seeing you in cardiology clinic. So at this point, her total cumulative doxorubicin dose is 340 milligrams per meter squared. And the oncologist asks you, what is considered a surveillance recommendation for this patient? Are there any other recommendations that you may give to mitigate the risk of cardiotoxicity? And we have to consider also what is a high dose of anthracycline treatment. So hopefully by the end of this talk, you'll have the answers to these questions. Here, I've plotted out the patient's doxorubicin dose, ejection fraction, and global longitudinal strain. On her pre-treatment echo, she had normal ejection fraction and strain, and actually was relatively normal until her final echo, in which she had received 485 milligrams per meter squared of doxorubicin, at which point her EF dropped to 39%, with a corresponding decrease in global longitudinal strain to negative 8.7%. And this is her 3D ejection fraction by echo. And this is her strain. On her pre-treatment strain, we see that the strain curves are very normal and her bullseye plot is completely red. On her post-treatment echo, her strain curves are much reduced and her bullseye plot is no longer completely red with lighter shades of red and pink. Cancer therapeutic-related cardiac dysfunction has many definitions, but probably the easiest one to remember is the one that's put forth by the American Society of Echocardiography, which is a decrease in ejection fraction of greater than 10% from baseline to a value less than lower limits of normal for the echo lab. This can be subdivided into reversible, partially reversible, and irreversible. Anthracycline cardiotoxicity is thought to have different phases. There's the acute phase, which happens immediately during infusion. This is very rare. It's transient and usually reversible, decrease in EF that improves with discontinuation of treatment. The subacute phase occurs within the first year post-treatment, and this is dose-related, usually irreversible, and can progress to clinical heart failure if not recognized. But we can never forget that a patient has received anthracycline treatment because there is a chronic and late phase that can occur even years later that is usually triggered by a secondary insult and is generally irreversible. These stages probably do represent a continuous spectrum of the same pathophysiology from acute to chronic irreversible, with increasing doses of anthracycline and coexisting risk factors that determine the rate of progression of cardiac dysfunction. The mechanism of cardiotoxicity from anthracycline is thought to be due to inhibition of topoisomerase 2 beta, which causes double-stranded DNA breaks, which activates an apoptotic pathway that interferes with mitochondrial biogenesis, generating oxygen-free radicals, which can cause direct damage to proteins, lipids, and DNA. The myocyte apoptosis is related to increased oxidative stress, which is caused by these processes. You can see here in this doxorubicin-treated mouse that there's vacuole formation, myofibril dropout, and apoptosis and necrosis. Heart failure increases with cumulative dose. In a retrospective review of almost, the incidence is almost 25% when the cumulative dose exceeds 550 milligrams per meter squared. And so a lifetime cumulative dose that's thought not to be exceeded is 450 milligrams per meter squared. Alexander and colleagues established LV ejection fraction as to monitor anthracycline cardiotoxicity with the MUGA scans in 1979, and this is almost 8 years after the first reported cases. It was initially believed that the 450 milligrams per meter squared dose was a high dose, and these curves were based on clinical heart failure. However, we now consider 250 milligrams per meter squared a high dose, and this is a dose in which we are seeing asymptomatic LV dysfunction, and we can see changes in the myocardium at even lower doses. So the risk factors for anthracycline cardiotoxicity include the cumulative dose, method of administration, including IV bolus administration, higher single dose, or dose-dense therapy, baseline low ejection fraction, older age, pre-existing cardiovascular disease, prior or concomitant mediastinal radiation, or other concomitant cardiotoxic chemotherapies. This is a seminal study. It's a very important study that looked at the importance of early detection done by Dr. Cardinali and colleagues. It was a prospective study in Italy over 8 years that looked at 201 patients who received anthracycline treatment and had an ejection fraction of less than 45%, and this was thought to be likely due to chemotherapy. Responders were defined as an improvement in ejection fraction to normal or greater than 50%, and all patients received enalapril and carvedilol that were titrated to maximum dose. As the time to heart failure initiation increased, the percentage of responders to heart failure treatment progressively decreased. Notably, there were no patients who had recovery of LVEF that was observed if the heart failure treatment was initiated after 6 months. In this schematic representation represents changes in the LVEF and timing of detection of subclinical cardiotoxicity to overt changes in heart failure. Cardiotoxicity can occur acutely or chronically with early onset after chemotherapy or late onset after many years. That is potentially by a second hit or other comorbidities. What do we have to help us with early detection of these changes? We have global longitudinal strain. These were the four main papers that were published between 2011 and 2013, which demonstrate the prognostic utility of global longitudinal strain in the detection of cancer therapeutic-related cardiac dysfunction that were used as the backbone for the current American Society of Echocardiography expert consensus statement. Of note, all of these papers were done in breast cancer patients who were HER2 positive who received serial treatment with anthracycline followed by trastuzumab. Dr. Scherer, Crosby, and colleagues found that monitoring global longitudinal strain by speckle tracking could identify patients at risk for anthracycline toxicity before a drop in ejection fraction. Anthracyclines have also been noted to lead to vascular stiffening, as demonstrated here in this elegant study, which looked at pulse wave velocities in the aorta in patients treated with anthracycline. Anthracyclines can also affect the right ventricle parameters, as shown here in this study of 74 patients with diffuse large B-cell lymphoma being treated with R-CHOP. There were changes in RV strain that occurred before changes in RV ejection fraction. These three consensus statement and guideline statements can help us with determining how to surveillance these patients. The American Society of Echocardiography expert consensus statement, the American Society of Clinical Oncology practice guideline statement, and as of this year, the European Society of Medical Oncology has also published a consensus recommendation. The ASE recommends integrated surveillance, including biomarkers such as troponin with echo parameters, LVEF, and global longitudinal strain. All patients should receive an echo prior to initiation of anthracycline treatment, and an echo again post-treatment, or if doses exceed greater than 240 milligrams per meter squared, then measuring an echo prior to each additional 50 milligrams per meter squared at the end of treatment and at 6 to 12 months later. ASCO recommends looking at both the patient's treatment as well as their personal cardiovascular risk factors. And if they receive high doses of anthracycline, high dose radiation, then these patients are considered high risk. However, if they're receiving lower doses of radiation or anthracycline, to also consider their risk factors. And if there's grade 2 or more personal cardiovascular risk factors with low dose treatment, then these patients are also high risk. And an echo is recommended in 6 to 12 month post treatment for symptomatic or asymptomatic patients who are high risk. The ESMO consensus statement as this year follows these recommendations, again recommending an ejection fraction be obtained at the end of therapy or within 6 to 12 months of treatment completion, and now also recommends possibly 2 years post-treatment and periodically thereafter. This statement slightly differs from the American Society of Echo in the reassessment of LV function following general imaging principles. So after 250 milligrams per meter squared, or its equivalent anthracycline dose of doxorubicin, approximately each 100 milligrams per meter squared. Beyond 250 is where they recommend surveillance, and at the end of therapy, even if the dose is less than 400 milligrams per meter squared. These echo guided clinical decision making is really central in cardio-oncology and is primarily based on ejection fraction. There's no recommendation to change chemotherapy guidance based on strain. This flow diagram nicely breaks down clinical considerations based on ejection fraction as well as strain. which can be used as a second objective marker of cardiac function. If there is subclinical LV dysfunction detected by strain, this is an opportunity for cardiologists to optimize risk factors, consider closer surveillance, and possibly consider cardioprotective therapy, although we are still awaiting research to support this. So anthracycline cardiotoxicity, how can it be mitigated? You can think of it in three areas with regards to patient risk factors, cardiac treatment factors, and oncologic treatment factors. The oncologic treatment factors need to be discussed with the oncology team with regards to modifying dose, modifying formulation, such as liposomal doxorubicin, modifying method of administration, such as giving it in a continuous infusion, or considering agents such as dexrazoxane. With regards to risk factor modification, this is especially pertinent with regards to hypertension management. And with regards to prophylactic administration of goal-directed medical therapy, this has been shown to be especially useful in patients who are receiving serial administration of anthracycline followed by an anti-HER2 therapy. Dexrazoxane is an iron chelating agent that is used can mitigate the risk of cardiotoxicity in patients given anthracycline. This was a large meta-analysis published this last year in JACC Cardio-Oncology that looked at 7 randomized trials and 2 retrospective trials of a total of greater than 2,100 patients. In this study, they did find that dexrazoxane reduced the risk of clinical heart failure and cardiac events, irrespective of previous exposure to anthracyclines. They also demonstrated that the rate of partial or complete oncologic response, overall survival, and progression-free survival were not affected by dexrazoxane. This study warrants further randomized trials before systematic implementation of dexrazoxane in clinical practice. This is another study I want to highlight done by Dr. Guglin and colleagues that was published in JACC in 2019, which looked at cardiotoxicity-free survival of HER2-positive breast cancer patients who received treatment with prophylactic beta blockers and ACE inhibitors. If you look at the entire group here, prophylactic therapy did not really have an effect in cardiotoxicity-free survival. However, if you separate out the group of patients who received anthracycline followed by trastuzumab, those patients benefited by either carvedilol, which is the blue line, or lisinopril, which represents the red line, over placebo. There are several ongoing cardio-oncology clinical trials. We're waiting for the results of the SECURE study, which is looking at EF surveillance versus strain surveillance with heart failure therapy being initiated for reduction in strain using ramipril and carvedilol, with the primary endpoint being the 3D ejection fraction. The PREVENT study, which has also been completed, which is a phase 2 double-blinded placebo-controlled study of atorvastatin 40 that was given to patients receiving anthracycline, breast cancer and lymphoma patients. Their primary endpoint was baseline to 6-month differences in LVEF that predicted baseline to 24-month differences in LVEF. This was an MRI study. And currently enrolling is the UPBEAT study, which is the largest multi-center study of its kind. Hopes to enroll 1,000 patients who are receiving anthracycline treatment. So just some final points if we go back to the questions that were asked during the initial case. What is considered a high dose of anthracycline treatment? The doxorubicin dose of greater than 250 milligrams per meter squared is now considered a high dose, but we can see changes at even lower doses. What surveillance recommendations would you give the oncologist? All patients receiving anthracycline treatment should get a pre-treatment echo with strain if possible. The echo should then be obtained at a 50 to 100 milligrams per meter squared, above a 250 milligrams per meter squared cumulative dose, so above a high dose. If a patient exceeds that, we should be surveillancing them very closely. Post-treatment, an echo should be obtained within 6 to 12 months for patients who are considered high risk for cardiotoxicity, and periodic long-term surveillance is also recommended by ESMO. What can we recommend to mitigate the risk of cardiotoxicity? We need to consider the patient's personal risk factor modification. We can consider prophylactic therapy in certain cancer subsets, such as HER2-positive breast cancer patients who are receiving serial treatment with anthracycline followed by HER2 agents, anti-HER2 agents. And in patients who are very high risk, we should be discussing with the oncologist whether cancer treatment can be modified. Thank you very much.
The speaker available for comment? The speaker available for the comments?
Pre-recorded, I think.
Okay. See, the real problem with the anthracycline-induced cardiomyopathy is less than 1% of the patients will only present acutely, immediately after the dose of doxorubicin. Typically, they will present at about 3 years or 5 years, whatever, 12 years, 20 years, like that. It's because there are a lot of compensatory mechanisms which works, which can compensate for the initial assault. Only 1% of the patients on doxorubicin will present with the fulminant cardiotoxicity immediately. So it's important in all these patients that we contain the risk factors like diabetes, hypertension, dyslipidemias, coronary disease, obesity, all sort of things, so that when these compensatory mechanisms fail subsequently as years pass by, and that's the real challenge involved because these patients present late. And the problem with the GLS is that it has not really made a big difference in the outcome of the treatment or management. The real the phase of adriamycin comes out when the dose exceeds for 550 milligram per meter square. Beyond that, it's really risky. And the children who are exposed to high dose of that will grow up with a smaller heart. And it's not really the apoptosis which really is responsible for the cell death. It's actually the necrosis, the cardiomyocyte necrosis. That's why it tends to be a permanent damage. Even though the cardiomyocyte damage is permanent, still the heart failure, the pump failure can be treated. So many of these patients, despite developing a little dysfunction, can still get the whatever chemotherapeutic agent that is the best for this patient. In case of recurrence, the patient has to get doxorubicin again, that can actually be given. That's what, in my experience at least, the number of patients which couldn't receive further chemotherapy was less than 1%. It's not that everyone with a little dysfunction should halt chemotherapy, especially doxorubicin.
Yeah, thank you, Rakesh. I think you're the expert among us regarding cardio-oncology. I think we had an excellent session. I'm really sorry about the studio, what happened here. The whole Neil Porter's audio just broke down. I couldn't hear any of these things. So while I was trying to repair it, then the cross-talking came. That's what really happened. I'm really sorry for that. I think we had an excellent session. Thank you, Dr. Wonder and Rakesh. We'll call it a day. See you. See you tomorrow.
Sir, thank you all, sir. Thank you all. Thank you all. Good night, sir.